Subcommittee holds a hearing on the state of America's mental health care services. Health officials from the Obama administration examine current challenges, focusing on the relationship between mental health and gun violence. It's 2.5 hours.
The Senate Committee on Health, Education, Labor, and Pensions will please come to order. My first order of business this morning is to extend a warm welcome to our committee's new members. In alphabetical order, Senator Tammy Baldwin, Senator Chris Murphy, Senator Tim Scott, and Senator Elizabeth Warren. This is a remarkably talented group of freshman senators, and we're glad to have them on board. I know that some are also over at the hearing on the Senator Kerry's hearing to be Secretary of State starting at the same time. I also want to salute our new ranking member, Senator Alexander. He has long been a valuable member of this committee. I've appreciated my relationship with former ranking member, Senator Enzi, and look forward to the same kind of close collaboration and partnership with my good friend, Senator Lamar Alexander. Today, our committee will examine a range of issues surrounding mental health care in this country. The tragic shooting in Newtown, Connecticut last month brought the issue of mental health care to the forefront of public dialogue. Many people across the nation, including the President, have said that we need to take a long, hard look at access to mental health services across the country. I'm pleased to have this opportunity today to start that dialogue with my colleagues and our panel of expert witnesses. I'm told this is the first hearing that this committee of jurisdiction, has had on this issue since 2007, so it's long overdue. Certainly one of the most insidious stereotypes about people with mental illness is that they are inherently violent. I regret that some of the discussion in the wake of the Newtown tragedy has sadly reinforced this stereotype. As my fellow committee members know, and our witnesses and experts know, people with mental illness are much more likely to be the victims of violent crimes than they are to be perpetrators of acts of violence. Mental health conditions are sometimes called the nation's silent epidemic. Mental illness affects 1 in 4 Americans every year. But despite its prevalence, there is still a stigma attached with mental illness, and that stigma results in too many people suffering in silence without access to the care that could significantly improve their lives. Stigma also can stop workers from requesting and getting accommodations that can help them be more productive at work. I've known so many instances of people who were afraid to do anything because they might lose their job, or they wouldn't get promoted because of that stigma that's attached. Unlike many other chronic diseases, mental health problems often begin at a young age. Experts tell us that half of all mental illnesses manifest by age 14. However, less than half of children with an identified mental health illness receive treatment, and the average lag time from the first onset of symptoms to receiving treatment is almost a decade. Unfortunately, the picture for adults seeking treatment is not much better. This lack of treatment has huge consequences. Some 30,000 Americans die by suicide each year. And it's a shocking fact that people with serious mental illnesses die significantly earlier than Americans overall, often from treatable causes like diabetes and smoking-related chronic conditions. These consequences also spill into other areas. As any teacher or school counselor will tell you, a child who is struggling with depression, anxiety, or any other mental health condition is also likely to struggle academically. It's also an issue for our justice system, since our prisons too often become the dumping ground for people who should be receiving mental health and substance abuse counseling instead. I have had a number of sheriffs in my own state, as well as other states, tell me that their jails are now the de facto mental institutions in their states. The shame in this is that with access to the right treatments and supports, most people with mental illness can recover and lead productive and healthy lives. But we need to make the critical investments that will enable this to happen. So wearing my other hat as the chairman of the Labor, Health, Human Services, Education Appropriations Subcommittee, I plan to take a close look at funding opportunities in this area through the appropriations process. We've made important steps forward in recent years. My friends, the late Senator Paul Wellstone, and again along with my friend Senator Pete Domenici, fought for years to try to enact a Mental Health Parity Act to end the absurd practice of treating mental and physical illnesses as two different things under health insurance. We finally passed that in 2008. However, I am sad to say it has been 4 years now, that we do not have any final rules on implementing this law. That's a shame. I am told the President said that they will be announcing a final rule soon. I don't know what soon means, but I hope it means what we generally take it to mean, which means soon. Another critical step will take place next year when, thanks to the Affordable Care Act, some 30 million Americans will become eligible for Medicaid or private insurance through the health care exchanges. Coverage of mental health and substance abuse disorder services is one of the 10 essential benefits required in qualified health plans. The insurance expansion here offers both challenges and opportunities. Experts predict that the newly insured population will have a greater need for mental health coverage than the general population. As we think about how to meet this need, there's an opportunity to realign our healthcare system to better integrate primary care and mental health services. And in reading over the testimony last evening of our witnesses, many of our witnesses spoke about that, this integration of primary care and mental health services. This committee, I think on both sides, have been very supportive of the expansion of community health centers throughout the United States. They've been a great addition. They're wonderful primary care providers. But how do we integrate mental health care services in with those community health centers and make sure it's part of primary care? 50 years ago, President Kennedy signed the Community Mental Health Act of 1963, which led to a major shift in mental health care in this country. People who were warehoused in institutions moved back into their communities. But the results were mixed. Many people were not able to access the community-based services and treatments they need. So as we face major new changes in the healthcare landscape, I hope we'll learn from these lessons. And again, as I said, see how we might more fully utilize the community health center system in America to integrate primary care and mental health services. So today we'll hear from a panel of expert witnesses who will talk about mental health care from a variety of perspectives, all with the goal, I hope, of addressing this critical but often neglected public health issue. I want to reemphasize that, in my own words, public health issue. So I thank you all for being here. Look forward to your testimony, and I'll yield to our ranking member, Senator Alexander.
Thanks, Mr. Chairman. Thanks for your courtesy. I look forward to working with you. We've worked well together in the past, and this is a very important committee with a large jurisdiction, and I'm delighted to have a chance to be the ranking member. I want to say to Senator Enzi how much I appreciate his leadership, and we expect it to continue as time goes along. I also want to thank the chairman for having this hearing and the way he's having the hearing. I mean, we're entering this discussion, so far as I'm concerned, and that's my sense of the chairman's attitude, with no agenda other than to learn what needs to be done. As the chairman said, we haven't had a mental health hearing for a while, and so I'm here to do a lot of listening. I was saying to some of the witnesses before the hearing that when I was United States Education Secretary, I often was sitting in their shoes, and I remember going back and telling the people in the department that I thought I was going to a hearing, but in fact it was a talking, because the senators did all the talking and the witnesses did most of the listening. So I hope this will be more of a hearing instead of a talking, and I'll try to do my best to make it that way. Seems to me that the question before us is who needs help and who's there to provide the help. We can hone in on that question and see what the federal government can do to improve our ability to determine who needs help and our ability to identify the person or agency whose job it is to provide the help. Then we will have provided some service. Helps to put a face on who needs help. As a former governor, I always look at things from my own background and perspective, as I know most of us do. About 22% of Tennesseans reported having a mental illness last year. That's more than 1 million more than 1 million people. This is according to our State Department of Mental Health and Substance of Mental Health. About 5% had a severe mental illness. That's nearly 250,000 Tennesseans. So that's a lot of people. About 41,000 Tennesseans had a major depressive episode. The funding that helps meet the needs for that comes in some part from the federal government. About 22% of what Tennessee spends, I'm told, is federal dollars. The rest is state dollars. In the community services, state appropriations are about 70% of the mental health fund. So while the federal government has a role here, it's a support role and a supplementary role, and it's a role that ought to make things easier instead of harder. In preparing for this, it seems to me that putting a face on the individuals who need help, one group would be a 9-year-old boy who's always been pleasant but suddenly started defying his teachers and his grades slipped, and he didn't want to go to Boy Scouts, he didn't want to play with friends, and so they reached out to a pediatrician who was able to get some professional assistance. He was diagnosed with a mood disorder, and he began to improve, was sleeping better, and so it was a success story for that 9-year-old boy. Another case might be an adolescent, a 17-year-old who had no behavioral issues growing up. He started noticing lights in the bathroom, sounds of water irritated him. He had trouble sleeping. He began to hear voices telling him to throw rocks at anyone who told him to come down from the roof. And he was finally diagnosed with schizophrenia, but only after he had multiple episodes. Those two boys represent two of the largest groups that need help, and I'll be interested in finding out from our witnesses how well we're doing in helping them get the help. Finally, I'll be especially interested in asking the federal agencies as well as the state and local witnesses who are here, what can we do at the federal level to make things easier to, number one, identify who needs help, and number two, identify who can provide the help? Are there administrative things we can do? Are there funding things we can do? Are we putting up any roadblocks that make it harder for you to provide services? If we are, this is the place to identify them and see if we can correct them. So, Mr. Chairman, I look forward to this. I thank you for holding the hearing.
Thank you very much, Senator Alexander. Now we'll turn to our witnesses. We have two panels. On our first panel, we'll start with Pamela S. Hyde, Administrator of the Substance Abuse and Mental Health Services Administration, obviously known as SAMHSA to all of us. Ms. Hyde was nominated by President Obama, confirmed by the U.S. Senate in November 2009 as the Administrator of SAMHSA. She is an attorney, comes to SAMHSA with more than 30 years' experience in management and consulting for public health care and human service agencies. She has served as a state mental health director, state human services director, city housing and human services director, as well as CEO of a private nonprofit managed behavioral health firm. Ms. Hyde is a member of or has served as a consultant to many national organizations, including the John D. and Catherine T. MacArthur Foundation, the American College of Mental Health Administration, the President's New Freedom Commission on Mental Health, and the United States Department of Justice. Our second witness on this panel, of course, is no stranger again to this committee, or at least to my appropriations subcommittee anyway, and Dr. Thomas Insel, who is the director of the National Institute of Mental Health, NIMH, at the National Institutes of Health. He has been director since the fall of 2002. Prior to that, Dr. Insel was professor of psychiatry at Emory University, and there he was the founding director of the Center for Behavioral Neuroscience, one of the largest science and technology centers funded by the National Science Foundation. He has published over 250 scientific articles and 4 books, including The Neurobiology of Parental Care in 2003. He's a member of the Institute of Medicine, a fellow of the American College of Neuropsychopharmacology, there I said it, and is a recipient of several awards, including the Outstanding Service Award from the U.S. Public Health Service. So we thank you both for your backgrounds, for what you have done in this whole area of mental health, both in research and practicality, and your statements will be made a part of the record in their entirety. I'd ask, we'll start with Ms. Hyde, I'd ask if you could sum it up in 5, 7, 8 minutes, something like that, and then we'll get to some questions. So again, welcome, and Ms. Hyde, please proceed.
Thank you, Chairman Harkin and Ranking Member Alexander, for holding this hearing today. It's an important day. You will hear today about the prevalence and burden of mental illness and about the critical needs in our country for understanding, treatment, and support services for those who experience mental health conditions. SAMHSA's mission is to reduce the impact of both substance abuse and mental illness on America's communities, and there's significant overlap between those two sets of conditions. They currently exist largely outside the mainstream of American healthcare, with different histories, structures, funding, incentives, practitioners, and even in some cases, different governing laws. It's time that changed. SAMHSA envisions a nation that understands and acts on the knowledge that behavioral health is really essential to health, that mental and emotional health and freedom from substance abuse and addiction are necessary for an individual, a family, or community to be healthy. As the Senator said, almost half of all Americans will experience symptoms of mental or substance use disorders in their lifetime, and yet of the over 45 million adults with any mental illness in a given year, only 38.5% of them receive the treatment they need. And of the almost 22 million adults with substance use disorders, only about 11% receive the treatment they need. For children and adolescents, it's only about 1 in 5 that receive the treatment they need for diagnosable mental disorders. Cost, access, and recognition of the problems are the primary reasons this treatment is not received. However, it doesn't have to be this way. For most of these conditions, prevention works, treatment is effective, and people do, in fact, recover. And as Senator Harkin said, the Institute of Medicine reported in 2009 that half of adult mental illness begins before the age of 14 and 3/4 before the age of 24. We can and must intervene early to address these issues for our young people and for our nation. Behavioral health is a public health issue, not a social issue, and it can be tackled and addressed in an effective public health approach driven by data, focused on prevention and supportive policies and services that treat and restore to health. I'd like to talk about the Affordable Care Act for just a minute because it's going to provide one of the largest expansions of mental health and substance abuse coverage in a generation by helping over 65 million Americans have access to additional behavioral health benefits that they do not have now. The ACA has already provided screening for depression, suicide risk, and alcohol misuse in many service programs and in its quality measures, and it has already provided additional coverage opportunities for youth. It will ensure that insurance plans offered in the new marketplaces cover mental and substance use disorders at parity with other benefits and as one of the 10 essential health benefit categories. As part of the President's plan to protect our children and our communities, he outlined some specific actions and initiatives to help ensure adequate coverage of mental health and addiction services. The administration issued a letter to state health officials making it clear that Medicaid expansion plans must comply with the parity requirements of the Mental Health Parity and Addictions Equity Act of 2008, or what we call MAPIA. In addition, the administration will issue final regulations governing how existing health plans that offer mental health and addiction services must cover them at parity under MAPIA. The President's initiatives to ensure students and young adults receive treatment for mental health issues include SAMHSA-led proposals such as a new program called Project Aware, which would bring together state officials, schools, communities, families, and youth to promote safety, prevent violence, and identify mental and behavioral health conditions early and refer young people to treatment. Project Aware would also provide mental health first aid training. A proposed new grant program, Healthy Transitions, would provide a pilot to model innovative state and community-based initiatives and strategies supporting young people ages 16 to 25. Along with HRSA, the President's workforce proposal would provide training for more than 5,000 additional mental health professionals to serve students and young adults. And finally, with the Department of Education, HHS will soon launch what we're calling a national dialogue on mental health to help change the conversation and galvanize action about our children's mental health. We've come a long way in the prevention, treatment, and recovery supports for mental and addictive disorders, but we have a long way to go, and we can do better. Thank you for your time today, and I'd be very pleased to answer any questions that you may have.
Thank you very much, Dr. Hyde. And now we'll turn to Dr. Insel. Please welcome again, and please proceed.
Thank you, Mr. Chairman and Ranking Member Alexander and members of the committee. It's a real honor to be here, and it's actually a great pairing to have Administrator Hyde and me on the same panel. This is essentially going from services to science. So as a person coming to you from the National Institute of Mental Health and the National Institutes of Health, my role is really around the research related to mental illness and thinking about how to come up with the science that will lead to better diagnostics, better therapeutics, better understanding of what you called a silent epidemic, Senator Harkin, and that's actually an interesting term for this. I know we haven't met for some years to talk about this, so it's particularly for us important to get this out on the agenda. It's clear that in some ways this is a response to this tragic event that happened in December in Newtown, Connecticut, and if it takes an event like that to focus the nation's attention on the needs of those with mental illness, it's terrible to say that, but at least perhaps one of the opportunities that can be taken now is to think about how do we do better by those with mental illness and how do we make sure that events like this don't happen again. I'm not going to read my testimony, and to save time, I think both Pam and I are eager to get to your questions. But perhaps to preempt some of those questions, let me take just a couple of minutes to make some of the points that might help in terms of how we think about mental illnesses, some of the definitions and the science as we understand it. First of all, when we talk about mental illness, we're talking about, as you have already heard, very common disorders: depression, PTSD, eating disorders, and there are many others. There are about 10 or 12 that we focus on. These are real illnesses with real treatments and affect about 1 in 5 Americans overall, including youth, as we'll say in a moment. Today, we're probably going to talk mostly about serious mental illness. That's a term of art that has to do with those people who are truly disabled, often by a psychotic illness. That occurs in about, overall, perhaps 1 in 20, so it's not quite as common. But it's an important piece of the story that we need to talk about because these are the people who are most severely impaired. As Pam mentioned, and as already mentioned by you, Senator Harkin, it's really critical for the committee to understand that unlike talking about cancer and diabetes and heart disease, when we talk about mental illness, we're talking about illnesses that begin early in life. These are, in fact, the chronic disorders of young people. And it requires a different mindset when you think about how do you detect, how do you intervene, how do you make sure that you can make a difference. It's one of the reasons why these disorders have the highest disability rating or the highest morbidity overall. It's because they start early and they tend to be chronic. As Pam mentioned, we know these are treatable disorders, but there's a significant delay in getting treatment, and even in those young people who have these most severe illnesses like schizophrenia, on average, the delay between the onset of symptoms and when they get diagnosed and treated is somewhere between 1 and 2 years, which seems extraordinary because you're talking about symptoms that are so disabling and so obvious. And it's especially unfortunate because the lesson we have learned from cancer and heart disease, diabetes and AIDS is that the secret to having the best outcomes is early detection and early intervention. That's what biomedical research has taught us over the last 4 decades. You have to get there early in the process if you want people to have the best outcome. And we don't do that here. And I think one of the things we need to talk about, again, going back to your comment, Senator Alexander, about who needs help and who's going to be responsible for providing help, is why the delay and how do we do better in making sure that people get involved more earlier in the process. Just a comment about violence and mental illness, because it will come up, I think. It's on a lot of people's minds. As you've heard already, most violence has nothing to do with mental illness, and most mental illness, or most people with mental illness, are not violent. In fact, we generally worry more about people with mental illness, especially severe mental illness, being the victims, not the perpetrators of violence, and the science certainly supports that. There are 2 conditions where we do need to think about this because violence and mental illness will intersect. And one of those is these psychotic illnesses like schizophrenia that start early and usually adolescence. For people who have not received treatment, they are at greater risk for violence, either because they're paranoid and and may irrationally feel that they are under attack, or sometimes because of hallucinations or voices telling them to do something horrific, as you mentioned with your example, Senator Alexander. Far more common, however, is the second issue, is not homicide or violence against others, it's violence against the self. Suicide is a far more common problem for people with serious mental illness. 38,000 suicides in this country each year with the most recent data that we have. That's more than one every 15 minutes. 90% of these involve mental illness. By contrast, there are less than 17,000 homicides with less than 5% involving mental illness. So when we talk about violence and mental illness, when we talk about safety and security, when we talk about access to means or duty to warn, the bigger problem here is suicide. It's protecting the person with mental illness as well as family members, peers, and people in the community. There's a lot that can be done here. We're not great at predicting. It's more still an art than science. And I would say that's true, by the way, of heart attack, cancer, as well as serious mental illness or violence in those people who are affected by these kinds of illnesses. But even without being 100% certain on the predictions at the individual level, we can do a lot towards prevention, and you'll hear something about that in the conversation today. At NIMH, we've really spent much of our investments focusing on the earliest stages of severe mental illness and identifying high-risk states before psychosis begins, just the way we do today with cancer and heart disease, and thinking about how to intervene early. So I think I will stop there, except to say that this is an extraordinary time in terms of the science of mental illness. We are really in the middle of a revolution because of what we're learning about the brain. We do think about each of these disorders as brain disorders, and we think about our interventions in terms of how they affect individual brain circuits. We've made tremendous strides over the last 50 years. You cited President Kennedy's launching of the Community Mental Health Program, which actually began with a special comment to Congress on February 5th, 1963. So we're almost exactly at the 50-year anniversary. A lot has happened in that time, but as Pam mentioned, we have a long way to go. And look forward to your questions about how we can do better going forward. Thank you.
Thank you, Dr. Insel. Now I'll start a round of 5-minute questions. Ms. Hyde, I just want to again focus on the Mental Health Parity Addiction Equity Act, signed into law 2008. A major accomplishment. I'm concerned because the interim final rule published in 2010 left some implementation details unresolved. When the administration publishes a final rule, how will you address issues such as the scope of services that must be covered so that insurers have the detailed guidance they need to implement the law?
Thank you for the question, Senator Harkin. As you know, the interim final rule was published in 2010. Part of what was requested from the public was input on several topics. That was one. In the meantime, we've issued 4 or 5 sub-regulatory guidance, frequently asked questions. We've also been meeting with stakeholders and with the industry trying to understand how the implementation is happening. We are ready to produce a final reg, and we're in that process now.
Thank you. Dr. Insel, I have some concerns, and I know others have also, and I've read a lot about these concerns, and I hear them from constituents and other people who talk to me about the use of pharmaceuticals, particularly antipsychotic medications in children. What I hear sometimes, a kid acts up, does something, get him a drug. Get him some antipsychotic medication. What do we currently know about the safety and long-term effects of these drugs in kids? As I've often said, children are not just little adults. They're different. And what might work in an adult, even you say, well, we'll reduce the dosage. That sometimes doesn't always correlate. I don't want to practice medicine without a license, but nonetheless, we know that to be a fact. What do we currently know about the safety and long-term effects of these kids, and what areas require further research and study?
Well, in fact, there is a real concern because the use of antipsychotics in children has gone up markedly over the last decade. And what we do know is that children are actually more sensitive to the side effects, particularly the metabolic side effects. And that's a real concern because often these drugs are used long term. So there's an issue. There's a real issue about practice and about improving the quality of practice in this regard. And I should say that some of this may be related to a reluctance for many clinicians to use antidepressants, which are probably somewhat safer, but there were concerns about suicide and actually violent behavior. The curious thing to know here is if you look at the other side of this, we're not talking about young children, but when we talk about adolescents and the example that Senator Alexander used about the 15 or 16-year-old who's beginning to hear voices and who's going down this path of psychosis, what tends to happen most often is not that people are getting overtreated with medications, but that they're not getting diagnosed and treated at all. And specifically with respect to our concerns about violent behavior, we know that treatment reduces that the most important thing you can do if you want to prevent new events like this, the ones that we've often talked about over the last now 5-6 years, is to ensure that people who are on this path to becoming psychotic and paranoid and grandiose and perhaps dangerous are treated. The risk of violence is 15-fold higher prior to treatment than it is after. And treatment often does involve antipsychotic medication. So it's not the whole treatment, but it is a part of making sure that people who are developing a psychotic illness are actually not going to become a risk to themselves or others.
We'll hear testimony later from the next panel about approaches such as mind-body connections and things like that in terms of perhaps especially as we get into prevention and we start recognizing in young children, in school and other places, certain types of behavior that maybe early on interventions with family counseling and therapy might be more successful than just giving them an antipsychotic drug. Do you have any comments on that?
There are only a few reasons to use an antipsychotic drug in a young child. Probably the most common and the one that is approved by the FDA is in autism, where there are forms of irritability and what you might call temper tantrums, in which children will hurt themselves or hurt somebody else, often very young children. And in that case, the FDA has approved the use of 2 different antipsychotic drugs to help control that kind of behavior. But for the most part, the medications that are approved for use in children and the ones that seem to show the greatest efficacy are in other classes, particularly for children who have, for instance, attention deficit hyperactivity disorder, where the psychostimulants have been shown over and over again over the last 4 decades to be not only high efficacy but high safety as well. And we know from long-term studies that that's helpful. So I wouldn't say that in any of these cases medicine is the whole answer, but it's often helpful as part of the answer. There are lots of other kinds of interventions that are being developed and some that still need to be developed that may be far more effective beyond medication. So this is just a part of the story.
Thank you very much, Doctor. My time is up. Ms. Hyde, do you have a short?
I just was going to say that from a population-based point of view for young children, there are interventions, not for people who've been identified with an issue, but in classrooms, for example, a program that we support called the Good Behavior Game, which has shown fairly remarkable ability to help teachers manage behaviors in classrooms that does have long-term impacts.
Thank you. Senator Alexander.
Thanks, Mr. Chairman. Ms. Hyde, it looks like, just looking at Tennessee, that maybe a quarter to a third of the funds that are available for mental health and substance abuse through the state government are federal dollars. Does that sound about right for the country? Is that your experience? You have 2 big, most of it goes through 2 big block grants, or 1 big one and 1 smaller one. Is that about right?
Sort of a rule of thumb is somewhere around a quarter of the funding for the nation. I don't know about Tennessee particularly, but is
but for the nation, that sounds about
it sounds about
right.
Right, if you take the Medicaid dollars and each state has different match, of course, so that changes how much is state dollars and how much not. About half the dollars that go for behavioral health in the country as a whole are public dollars, federal and state.
Do you regularly consult with the state mental health directors about your 2 block grants and how they're administered and how the money is, and how you might improve the process of applying for that money and make it easier for them to help the people who need help?
Absolutely, Senator. We put out a block grant application. It's now a uniform application that makes it easier for states to apply for the funding. We go through a public process as well as informal process of asking for input from the states and the 2 state associations that represent state agencies in that process.
I've heard that the statutory deadline for the 2 block grants is in the fall, September and October, but that you've indicated that you've moved that up to the spring, and that's causing some states to have concern about being able to get ready for the applications because of the legislative sessions, and that there's some confusion about how much information is requested, and if as much as is requested as it appears to be, that it might be burdensome. Have you heard that from state directors, and if so, what are you doing about that?
Thank you, Senator. Actually, interestingly enough, we actually changed that date initially in consultation with some states. What we were trying to do is push up the date so that they could do it their planning during their legislative process, so that as their legislature decided match monies, or what we call maintenance of effort monies, it could be tied to the block grant dollars. Yeah. Since the application is not yet out, we probably will change that date before the final application comes out.
Well, could I encourage you to take a look at that and make sure that it's not a burden on the states? And
absolutely.
You mentioned the mental health parity letter that came out earlier this month. Did the mental health parity law apply to Medicaid as by its terms, or does it apply to Medicaid by the terms of the new health care law? Or is the letter something that expands the application of mental health parity to Medicaid?
The letter just explains and provides guidance to states about how MAPIA, so how the federal law about parity, applies to certain portions of the Medicaid program. Mm-hmm. So Medicaid benchmark plans and benchmark equivalent plans, they're called, or alternative plans, are subject to MAPIA, whereas the basic underlying Medicaid program in the states are subject to other laws.
So it shouldn't be any surprise to governors who are evaluating the cost of Medicaid expansion that the mental health parity law applies to Medicaid.
Senator, I don't know if it's a surprise. It is, in fact, applies to certain portions of it. So part of the reason for the letter was to try to describe the differences about where it applies and where it might not.
Yeah. That's helpful. I've heard from a number of governors who haven't made a decision about Medicaid expansion that it's hard for them to make that decision without knowing the added cost of it to the states, as Medicaid has grown as a part of state budgets, for example, in our state from 8% when I was governor to 26% today. So did you detail in your letter what the added cost to the federal government or states would be as a result of the application of mental health parity to Medicaid?
No, the letter was not about cost, although as Congress went through the process of passing the MAPIA, or the Mental Health Parity and Addictions Equity Act, there was significant discussion about cost. And all the studies that have occurred have indicated that the cost is negligible. And in fact, MAPIA does allow a plan to request an exemption if their costs go over a certain amount. So that is part of the MAPIA law.
Thank you. Thank you, Mr. Chairman.
Thank you, Senator Alexander. Now, as you know, there's been a sort of a tradition or rule of this committee that senators are recognized in order of appearance, and I have here Senator Murray, then Senator Enzi. We go back and forth, and Senator Baldwin, Franken, Murphy, Sanders, Mikulski, Whitehouse, and Warren. So I would now recognize Senator Murray.
Well, thank you very much, Mr. Chairman, for holding this really important hearing, and it is, I think, especially important to note Obviously, the issue of Newtown focused everybody on it, but this is an issue that a lot of us have been working on for a very long time, yourself included, and I think it's a great time to refocus. I think it's really important that it's your first hearing, and I appreciate that. And Senator Alexander, welcome you to the new ranking member position and look forward to working with you. And all of our new members, great to have you on this committee. There's a lot of great talent here. Mr. Chairman, I think that we'll really be able to do some good things with this committee. So thank you very much, and to both of our witnesses as well. I did want to go back. Senator Harkin has mentioned it several times, but in the President's recently released gun violence package, he issued 3 parity provisions, one clarifying parity for Medicaid, managed care plans, one saying that a parity provision would be included in the final essential health benefits rule, and one that committed to issuing the final rule on the Mental Health Parity and Addiction Equity Act, which you've mentioned. But it didn't make clear, and you haven't yet made clear, when we're going to actually see that. If these plans are supposed to go be ready to go into exchange starting in October, it's really essential that we see a final rule on this before April. So let me go back to the question that Senator Harkin asked again and ask you to be specific about a date that we will see this final rule in place.
Thank you, Senator Murray. I think the President's proposals indicated that the essential health benefits rule would be out next month. We are working on the parity, the MAPIA final reg, and it will go through the regulatory process and is in that process now. I can't give you a specific final date, but we are on it.
Will we see it by April?
I can't tell you precisely what the date is, but we are on it now.
Okay, well, it is really essential because our states are working on these exchanges and they need that clarity to move forward. So I can't urge you strongly enough that that date is critical. Mr. Chairman, one of the issues I have focused a lot on in terms of mental health, obviously, is our military families. And I just continue to believe we have to do everything we can for our veterans and our service members as they transition, especially during difficult periods of redeployment and returning home, transitioning back into the civilian world. But the focus also has to be on the families of these veterans, and I'm certain that is the same throughout all of the mental health, whether you're talking about military or you're talking about a number of the other topics you've been talking about. The Mental Health Access Act that we wrote included provisions to expand some of the VA mental health services to family members. Can you tell me how you've been progressing in implementing the Military Families Initiative?
Yes, Senator. We have, you may recall that the President issued an executive order in the fall asking HHS and DOD and VA to collectively work on improving the mental health access for service members and veterans. We're actively working on that together, the 3 departments. Part of the way we're trying to get at the whole family and the whole needs of the individual is looking at partnerships between community health centers, community mental health centers, and VA organizations. There are times when family members cannot access Veterans Administration, but they can access the mental health center down the road, or vice versa. And so we have been trying to look at pilots. The executive order called for working on pilots. We're doing that. And we've also been meeting with stakeholder groups, and some of those stakeholder groups have been families of veterans, service organizations, and others, giving us their input about the best way we can provide that. We have a report due to the President by the end of February, so we're actively engaged in that process.
Okay, I'll really look forward to seeing that. And Senator Sanders is taking over the Veterans Committee, and he has a strong interest in community health centers as well. So I know we'll continue to be able to push on that, but I think it's really important that we focus on that for our military families. And Dr. Insel, thank you so much for talking about the importance of reminding all of us that mental health it doesn't mean that someone is violent. I think that's really important to remember as we go through this. And of course, we do need to focus on that population that has the potential to becoming violent, particularly at the younger ages. So, Mr. Chairman, I think that's why this hearing is so essential, and I really appreciate it and look forward to hearing the testimony of the rest of the panels. Thank you.
Senator Renzi.
Thank you, Mr. Chairman, and I want to congratulate Senator Alexander, who gave up a leadership position on our side in order to be the ranking member on this committee, and it shows his dedication to health and education and workplace safety and training and pensions, and I know that he'll do an outstanding job. So, and I appreciate you holding this hearing on mental health as the initial one. And my first question's for Administrator Hyde. I want to know more about the coordination and collaboration of agencies at the federal, state, and local level. Within your appropriate role as a federal agency, what needs to be done to better enhance that coordination and collaboration of agencies at the federal, state, and local level?
Thank you for that question, Senator. We've actually been trying very hard to recognize the relationship between states and local communities, because the state often will create laws, rules, regs that, of course, the community has to respond to. So when we provide grants, for example, to our communities, we're trying to say, how does this relate to your state's plan and a direction? Likewise, when we're providing grants to our states, we're trying to ask, how are you bringing your communities into that process? So we are, by our grant making, trying to bring them together. Through our community block grant application process, we're also asking how these things relate to what's going on at the community level. And then we have been providing significant technical assistance, because there's a lot of change going on in the health delivery system, to both our states and to our provider agencies, which provide the basic community infrastructure. We also have county-based programs that we do a significant amount of work with. So we're trying to look at those relationships. I personally have had the opportunity to work at all of these levels: city level, county level, state level, and now the federal level. And sometimes what you feel is where you sit, but I understand probably only too well how much those relationships matter. So we are working on them significantly.
Thank you, and I look forward to any suggestions you might have. Dr. Insel, what do we need to do to close the gap between research and real-world practice to ensure that evidence-based treatments are available in the community service settings?
Well, thank you. It's a question that we discuss a lot at NIH, not just within the mental health arena, but across all of the diseases for which we're responsible for providing better science. You know, the typical response to your question, or the typical assumption behind it, is that there's a sort of 17-year gap between a discovery and implementation. And so what we used to talk a lot about was, how do you move from research to practice? Interestingly, I'd say in the last 2 or 3 years, there's been a transformation in how we talk about this. And increasingly, we're beginning to say, you know, how do we move from practice to research? How do we make sure that we've developed not just healthcare systems, but learning healthcare systems that are involved in the research process itself? And so at NIH, we've created several efforts to do that, involving millions of patients through large healthcare systems like Kaiser and many others, in which we are doing research, where we're doing actual practical trials in these very large groups, much reduced costs. But the advantage of that is that you're making discoveries in the place where they will be implemented, rather than doing it, for instance, in an academic center where there may still be a gap to getting into the community. And the other piece of that that's so important, and it's actually part of the new institute that was formed at NIH, NCATS, is actually bringing in the community at the get-go and making sure that the kinds of questions that are being asked by science are going to give you the kinds of answers that people in the community are looking for.
Any reinvention is always appreciated for both of you. What type of oversight or financial controls are in place to ensure that federal funding is being used effectively to prevent and treat substance abuse, disorders, and mental illnesses? What needs to be done? What changes are needed?
I'll start with that question, Senator. For almost all of our programs, we do an evaluation of the program to see what kind of outcomes we're getting and what the what the results are, and we try to use those evaluation results in how we do the next round of program activities. We also provide some of the largest amount of surveillance data in the area of behavioral health, both substance abuse and mental health. And we're trying increasingly to use that data to help us understand where we need to go. We're working on something called the National Quality Framework, National Behavioral Health Quality Framework, which is a second step from the National Quality Strategy that was recalled for in the Affordable Care Act. And in that, we will be laying out the framework for a quality direction for behavioral health as a whole at different levels. We also obviously collect information and data from each of our grantees, and we are trying to make some improvements in that by streamlining our data collection systems. So we have multiple systems now. We're trying to put into one that's we hope is more effective and easier for states and communities to report into. So there's a number of activities that we're going through around accountability and evaluation, and we work very well with NIMH, NIDA, NIAAA at the way that their services or the research that they provide and how we can bring it into our practices as well.
My apologies, I've used up more than my time. Dr. Insel would answer that in writing, and I'll also be adding a question about duplicative programs between all agencies.
Look forward to it. Thank you.
Senator Enzi, and now Senator Baldwin. Welcome to the committee.
Thank you, Mr. Chairman. I am really delighted to join the committee and very pleased that the first hearing in this committee this session is devoted to this incredibly important topic. Ensuring access to quality and affordable health care has been and will always continue to be a very high priority of mine. And when I say health care, I don't distinguish between physical health and mental health, because to me they should be viewed as one and the same. The Mental Health Parity Act and the Affordable Care Act both take important steps to make this vision a reality. And together those two laws will both expand health care insurance coverage to millions of previously uninsured Americans and increase access to mental health care for millions more who have health insurance coverage. So my first question relates to increased access to insurance coverage. As we speak, governors across this country, including in my home state of Wisconsin, are grappling with the decision of whether to expand Medicaid coverage under the Affordable Care Act. In my home state, around 200,000 Wisconsinites could gain Medicaid coverage through the Affordable Care Act, Medicaid expansion, should our governor make that decision. So, Ms. Hyde, I really want to appreciate the fact that in your testimony you pointed out that Medicaid is currently the #1 payer for mental health services in the United States. We know that many vulnerable Americans do not currently qualify for Medicaid coverage. So in your opinion, how might states that are grappling with this decision, states that are choosing to expand Medicaid coverage under the Affordable Care Act, improve mental health outcomes for their most vulnerable citizens? Or perhaps alternatively, what variation might you expect to see between states that choose to expand Medicaid and those that don't with regard to treatment of mental illness?
Thank you, Senator, and welcome.
Thank you.
We are very optimistic that as states go through their processes that they will come to the decisions to provide the opportunities for coverage for their citizens. And in that process, obviously, each state looks at its own Medicaid program. However, the letter that we just recently put out was an attempt to try to help states understand how they should be looking at mental health and substance abuse treatment within those contexts. There are certainly services that we know can work. We're working very closely with the Medicaid agency, so CMS, our partner agency, in putting out informational bulletins on how states can use their Medicaid program to increase access and to do better for behavioral health. We are working with them to do that. We also, frankly, are working on the enrollment and eligibility process with the department as a whole, because we know that people with behavioral health needs, typically even after fuller coverage, have a harder time staying covered. So we are doing both, trying to get access through enrollment and eligibility, trying to get access through the type of service or the array of services that might be provided, and just trying to provide information to help states understand what's the most effective way to provide these services and the kinds of services that are most cost effective and most effective for treatment.
Thank you. One of the ways that we've already seen expansion of access to care, and you were talking in your testimony today about the barriers being cost and access, et cetera, is the provision in the Affordable Care Act that allows young people to stay on their parents' health insurance until they're 26. Something I'm particularly proud of, because I worked very hard on that in the House Energy and Commerce Committee, and we're pleased to see it in the final act. I'm wondering, especially given that your testimony talks a lot about the age of onset of many profound mental illnesses being between 16 and 25, whether you're already observing the positive impact of that increased level of insuredness for that age population, that age cohort.
We certainly know that both the provision to allow young people to stay on their parents' insurance and also the provision to prohibit exclusion from pre-existing conditions both help young people with mental health and substance abuse disorders stay on and keep insured, or be able to get access to insurance when they may not have access to it otherwise. Millions of young people are covered through that process already, and we know, I don't have a specific number, but we know that those young people who have these disorders are part of that group.
Thank you, Senator Bolton. Senator Murkowski.
Thank you, Mr. Chairman, and I join the rest of my colleagues in thanking you for calling this hearing on an incredibly important subject. I'm told by my staff that we haven't had a hearing in the Health Committee on mental health issues since 2007, which is way past time. So thank you for your attention to this. I have been focused on the issue of suicide for years now, and particularly youth suicide in this country. In my state, we have some very troubling statistics in areas, but the one that I find most disturbing is our statistics when it comes to youth suicide. In the country, the rate of suicide was 11.5 suicides per 100,000 people. In Alaska, we're looking at a suicide rate of exactly double that, 21.8 suicides per 100,000 people. And even worse are our statistics as they relate to our Alaska Native young men. Those between the ages of 15 and 24 have the highest suicide rate of any demographic in the entire country, at a rate of 141.6 suicides per 100,000 people per year, and this was between 2000 and 2009. For us, it's staggering, and it's something that I just find so troubling in everything that we do, that we cannot seem to be making inroads here. So I have long been focused on it. I've just reintroduced, along with Senator Reid, legislation that will help to address the youth suicide, and this is the Garrett Lee Smith Memorial Act reauthorization. We've got a good group of co-sponsors on that. But what we're seeking to do is to provide a focus on youth suicide in several different areas, to provide for prevention programs, and also, in addition to providing these grants to states and tribal organizations, but to colleges and universities as well. And the question that I would have for you as director here is how we can do more within our colleges and within our universities to provide for identification, early treatment, early intervention and the treatment services that might make a difference with our young people in our universities. We see these documented mental health needs. I'm concerned that we don't have sufficient flexibility within the programs that currently exist to help address this need. Can you speak to your observations and what we could be doing better to address those in our colleges and our universities?
Senator, thank you for the question. As you know, the Surgeon General, along with a very strong public-private partnership last September, put out Surgeon General's national strategy for suicide prevention. And in that strategy, there were several high priority things identified. I can't have the time nor the memory to go through all of them at this moment. But there were some very key things, like identifying, even as we've been talking about it in this youth age group, raising awareness so people know what to look for, having people be able to get help better, engaging aftercare, to use that term, so when people do have risk of suicide or they make a suicidal attempt, then follow up to make sure that there's adequate follow-up, because we know that's a high-risk time. Providing clinical standards so that clinicians know how to do the screening, and that includes in campus-based programs. We're proud to administer the Garrett Lee Smith program, and we see great results in terms of raising that awareness. And part of the President's proposals also include the idea of a mental health first aid approach and trying to get people more aware, especially focused on youth, of what to look for, how to get help, how to know someone needs help, and how to help them get that.
Well, I would hope that we could work with you on this. Again, this is a key issue for us. Dr. Insel, let me ask you a quick question. It has been noted by my colleague Senator Baldwin that the identification of mental illness in terms of recognizing what we're dealing with. Onset is as early as age 14, and that the early identification can really help with improving outcomes. And yet most of our primary care providers that are out there are probably not adequately prepared to identify mental illness at its earliest stages or provide for that appropriate care. What can be done? What is the administration doing to support primary care, improve these training opportunities so that we can do that early intervention, that early identification?
It's such an important question, Senator, because as we talked about earlier in the hearing, the lesson that we've learned over and over again in biomedical research is that early detection and early intervention give you the best outcomes. So we do need to do better at this. And it's challenging in this sphere because we do not have biomarkers the way we do for heart disease or cancer or many other diseases, where we can take a blood test and know who has what or who's on the high-risk path to develop something. NIMH is invested very heavily in developing just those kinds of tests, whether they're cognitive or biological, to know who's in a high-risk state. But that's a long-term plan, and I don't think we can wait to make sure that there's better awareness and better community support. And so one of the things that you heard, and Pam's already spoken to this, is Project Aware, which was announced last week by the President, which is an attempt to go out and increase awareness in schools, in primary care, in communities about the challenge that we face, the need to be able to detect the earliest signs. At the same time, recognizing that there are a lot of teenagers who are struggling, and you don't want to label every one of them as having an illness. So you need to be sensitive to getting better and better, more precise measures about who really is at risk and knowing who to intervene with. So we've got to find the right balance here, and hopefully science will bring us some better tools for that.
Thank you. My time's expired, Mr. Chairman. I apologize I've gone over. Thank you.
Okay, and now Senator Franken.
Thank you, Mr. Chairman. Like all members of this committee, we thank you for calling this hearing. I want to welcome Senator Alexander. as our new ranking member. I look forward to working with you. And I want to thank Senator Enzi for his work as the ranking member. Like everyone on this committee, I was devastated by the tragedy in Newtown. And in the wake of this tragedy, there's been a new focus on mental health issues, which I've been working on for a long time. Paul Wellstone held the seat that I hold, and I too share the sense of urgency about the rules on Wellstone Domenici being finalized. While I'm glad we're focusing on mental health, I think it's important not to stigmatize people with mental health or generalize about the connection between mental illness and violent behavior. And I want to thank both of you for making that very clear, that, as Ms. Hyde said in written testimony, most people who are violent do not have a mental disorder, and most people with a mental disorder are not violent. And Dr. Insel, you said essentially exactly the same thing. We should make sure that everyone has access to mental and behavioral health services that they need, because it will make our communities and families and them healthier and happier. But again, I think it's absolutely vital that we not stigmatize mental illness in the process. I think it would not only be counterproductive, but counterfactual. In the next week, I'm going to be introducing 2 bills that will expand access to mental health services. I'll be introducing the Justice and Mental Health Collaboration Act. It's really a reauthorization of an improvement, I hope, upon MIOCRA, and this is about when people with mental health issues encounter the criminal justice system, and it's a very I have 7 Republican sponsors on that, including Senator Hatch on this committee. I'm also going to be introducing the Mental Health in Schools Act, which dovetails with Project AWARE. And this is where, Dr. Insel, your testimony and your testimony too, Ms. Hyde, is so important. And it's about schools identifying and treating and giving access to treatment to kids. The statistics you mentioned, only 1 in 5 of children who have a mental health issue get seen or treated. My legislation will allow schools to collaborate with mental health providers, law enforcement, and other community-based organizations to provide expanded access to mental health care for their students. It will also support schools in training staff and volunteers to spot warning signs in kids and to refer them to the appropriate services. And I'm glad that that Project AWARE has the same kind of focus. I want to ask about the evidence in terms of, with the caveat that both of you made about not stigmatizing mental illness and associating it with violence, that if mental health issues go untreated, does that increase the chance that someone in a certain subset of a type of mental illness will become more violent, Dr. Insel? Or will be a higher chance that they might become violent?
So, Senator Franken, within that narrow band of the people we're talking about, which is a small segment of the population of people with a mental illness, but those, for instance, who have what we call first episode psychosis, we know that the duration of untreated psychosis is related, in fact, to the risk for having a violent act. That's been studied quite carefully, and there's a real correlation there. So closing that gap is one of the things we can do to increase safety.
So since, in a sense, Newtown did prompt this, in that very narrow, and that was one of a number of horrific occurrences where I think that no one would question that in Tucson, in Newtown, that we're talking about someone who's deranged, that had that person been diagnosed, say, in school, and had been able to get some kind of treatment, that there is some kind of connection between making sure that we're identifying and treating children early on with the tragedy that brought us here.
So I'm not going to speculate on those individual cases because I haven't seen them, but the data, the published data, are quite clear that the difference between severely violent acts like homicide, between those who are untreated and those who are treated, is 15-fold. So you drop the risk 15-fold with treatment. So it's vital. It's absolutely vital that we detect earlier and intervene earlier with something that's effective.
Thank you. And thank you, Mr. Chairman.
Thank you, Senator Franken. Let's see, Senator Murphy is left right now. Senator Sanders.
I think Senator Mikulski had an engagement, and she wanted to ask just one question.
Sure, absolutely.
Thank you very much, Senator Sanders. I have a meeting with Senator Shelby to help organize the Appropriations Committee, and that will take me, thank you, to really the questions for Dr. Ensel and Dr. Hyde. I think what we're hearing today is that effective intervention, whether it's autism or chronic schizophrenia, it's research, it's treatment, and the workforce to make both happen. So my question to each one of you, if we could just take the issue of research and then perhaps of workforce, but particularly on research. Dr. Ensel, what will be the consequences of sequester on the work at the national institutes, your national institutes of mental health? You've talked about this outstanding work that you're doing. What will happen?
At this point, what we're looking at is about a 6.4% reduction in the 2013 budget. And of course, that will come, if it happens, sometime in March or April.
What are the consequences?
Well, there'll be certain studies that we would like to do that are not going to be done at that budget. And one of the major projects that we're involved with is actually highly relevant to this discussion today, which has to do with how do we ensure that we have the kinds of predictors for early psychosis. We have a large national study in what we call the prodrome that we would like to scale up. And that's probably not going to be done if we don't have the funds to expand what we're currently doing.
And so there would be others along those lines. Now, Ms. Hyde, when one looks at the operation under your organization, what would be the consequence? And you can't have mental health without mental health practitioners, which usually goes to training grants, educational grants, actual workforce needs, particularly, as you know, at the state and local government. Would sequester have any impact on workforce issues? And what would they be?
Well, Senator, I think it goes without saying that we all hope that sequester, which was never really intended to happen, doesn't happen. But SAMHSA does a lot of technical assistance and training, and we provide a lot of materials and practice improvement for the workforce. And to the extent that we don't have the same number of resources to do that, then less of that will certainly be able to be done, and less of the grants that we put out as well.
So what, will it have a direct impact on training?
Senator, very well could. We, again, we have a fairly significant portfolio in providing what I call workplace or practice improvement efforts, and that, again, includes training, technical assistance, materials, just access to resources. So those all take resources to do, and to the extent that we have the resources, we do it, and if we don't, then we do less of it.
Well, I get a picture, and we will be coming back for more detailed questions on that. But I think it's this looming threat is severe, and I'm sure it has a tremendous impact on morale. But Senator Sanders yielded his time to me, and Senator Sanders, I appreciate it. I know you're keenly interested in that area as well. Let me just say one word. the reason I asked about the training, I went to graduate school on an NIH grant. When this 1963 bill was signed for mental health community centers, I was a social worker working as a child abuse worker. Because of that, at age 27, I was able to go to graduate school and get a master's in social work. Now, many might not think, and I was supposed to specialize in community mental health. Now, many might not think I have a therapeutic personality. But I did learn a lot, and I learned a lot that these scholarships and so on make a difference in lives, and you have the consequences of well-trained people and what they then produce in our society, I know is important.
We hope your training is successful in the appropriations process as well, so thank you for doing
I intend to be very agitated about a lot of things.
Thank you very much, Mr. Chairman. And Newtown and other events have highlighted the importance of this issue, and I very much appreciate your holding this hearing. Let me start off. I'm going to approach the issue in a little bit different way, Mr. Chairman, than some of our colleagues. The United States of America is the only country in the industrialized world that does not have a national health care system. In my view, in the midst of major health care crises in this country, including 50 million people today without any health insurance, hopefully that number will be significantly reduced under the ACA. The reality is that when you don't have a system, you're not prioritizing. So what that means, not only are we not paying adequate attention to mental health in general, but the disparities based on income and where you live are also enormous. Senator Murkowski mentioned the problems in rural Alaska, Native Americans. What I can tell you, and I want you to deal with this for a moment, if I'm making $500,000 a year and I'm living in New York City and my kid has problems, the likelihood is I'm going to be able to get reasonably good mental health treatment for that kid. That's the likelihood for my kid. On the other hand, if I live in rural Vermont and I'm making $25,000 a year, you know what? I'm going to have a very difficult time accessing the mental health care that my kids need. That's true, I suspect, in Tennessee, and I suspect that it's true all over America. The reality is, right now, that we have a primary health care system which is a disaster, that whether it is physical illness or you made the point that we do well with mental health when people can access the system when they need it. In my office, I can tell you we get calls in Vermont where family members say, I have my kid, my husband, serious problems. I can't find mental health treatment now. So let me ask you a simple question. If our goal is to make sure that mental health care is available to all people who need it, how many thousands and thousands of mental health practitioners does this country need, and how do we get them? Dr. Insel, why don't we start with you?
So I'm going to turn to my colleague who's just completing a workforce assessment, and so she's actually looked very carefully at this issue.
Decide how many thousands of mental health practitioners do we need?
We don't have good studies that say how many we need. We have lots of data that tell us what we don't have. And we have lots of data that give us comparisons between certain areas and certain types of practitioners. We are just completing a report for Congress on that. It'll be ready soon.
Well, before we even get to the report, and we need good data, tell me, is it fair to say that if I am a low-income person living in rural America or urban America, today I am going to have a very difficult time finding mental health care for my loved one?
Senator, I was actually going to go right there, so thank you for the question, which is, it's not even so much, although clearly in certain areas of practitioners we don't have enough, but it's also the distribution. The distribution is, I come from New Mexico, so we have major rural areas in New Mexico, and there are counties in New Mexico that don't have any behavioral health practitioners, none, zero. We have something like 75% of the psychiatrists are in what we call the Rio Grande corridor.
Which, let me guess, is probably, not knowing anything about,
Albuquerque and Santa Fe, yes.
a wealthier area.
Well, it's more urban, certainly, yes, and where the universities are.
All right, we don't have a whole lot of time, so my question is, if I am a working class person, if I am unemployed in this country, is it a fair statement to say, especially if I'm living in rural America, that it will be very, very hard for me to access affordable mental health care in a timely manner? Is that a fair statement?
I think it is fair to say that rural areas have a more difficult time. There are clearly programs like community mental health centers, like community health centers that have been explicitly
Well, I worked
set up
very hard.
for
Let me
that.
just interrupt you. I'm sorry. I apologize. We don't have a lot
That's
of
all
time.
right.
I worked very hard to double the funding of community health centers and triple the funding for the National Health Service Corps. I think we made progress. Would you agree that we need a long, long way to go to expand even beyond where we have gone in recent years?
I would agree that we need more practitioners, absolutely.
And I would add to that it's not only across the board, but there are particular areas of need that need attention. One of them is in children. So we've been talking a lot about youth needs. Child psychiatry is way underemployed.
Absolutely.
And child psychology is incredibly important to build the workforce.
All right, let me just conclude. I think it's a class issue too, Mr. Chairman. I think to some degree psychiatry is something that is accessible for urban, upper-income folks. It is not accessible for low-income, rural folks. So I think the point that Ms. Hyde made is an important one. We have to look at geography, and we have to make sure that mental health is available to all people, regardless of their income, all over this country. Thank you, Mr. Chairman.
Thanks, Senator. I might just add that since I focus so much on prevention and early intervention right now, school psychologists, the national average is 1,500 to 1. The recommended ratio, I don't know recommended by whom, is 700 to 800 students per psychologist. So we need to double that if we're even going to meet a recommended level of for kids in school. Senator Whitehouse, Senator Warren, welcome to the committee.
Thank you very much. Thank you very much, Mr. Chairman. Thank you. It's good to be here. And I also want to apologize for coming in late. I have the best possible excuse. I was introducing my senior senator, Senator Kerry, to the Senate Foreign Relations Committee, and I believe that will not be a recurring event. So,
Is that your way of saying soon you will be the senior senator from Massachusetts?
yes, sir, it is. So I thank you. I would like to start with my questions in the same place that Senator Enzi started. I have a very similar interest in the questions about research, around evidence-based medicine, around accountability, around our funding for research. So what I'd like to do is just start with you, Dr. Insel, if you would, and ask you to do two things for us. The first is just paint us a little bit of a picture about what we can do with research in the mental health field. If we get some good research, what can we learn that we don't know? And to talk just a little bit about what funding levels are doing to research.
Well, thank you for that question. I don't usually get an opportunity to talk about this, and I promise I'll do it very quickly. But you're asking the question at a critical moment in time. We are really, in the case of understanding mental illness, where we were in some ways for studying cancer 20 or 30 years ago. We're just on the cusp of a revolution, and it's because we have these extraordinary tools now. And for the first time, we can approach problems of the mind through studying the brain. And that gives us a kind of precision that we've never even imagined we could have. The reason that's so important is because for behavioral problems, whether they're in Parkinson's disease or Alzheimer's disease or Huntington's disease, the behavioral symptoms are a very late event. Those are the heart attacks. And it's the same thing, we believe, for the psychosis in schizophrenia. We define these as behavioral disorders, but in fact, they're brain disorders. And the brain changes are probably occurring years earlier. And if we want to detect and intervene earlier, we're going to have to be able to develop ways to to get at that, to understand them as brain disorders in the same way that we've done now in many other areas of medicine. So I think where the science is taking us is towards the biomarkers, is towards the fundamental biology. We have not been there before. We've had a very simplistic approach to this. It is far more complicated. The good news is we've got far better tools to be able to unpack this. Your question was about the funding. It's a challenge. There are lots of questions, lots of things we'd like to answer. I'd have to say that for NIMH, the shift has largely been to move much of our funding to people who actually 10 years ago were studying cancer and heart disease, who are now joining us because they feel that autism and schizophrenia are the new frontiers. And these are the places where you're going to make the big breakthroughs. It's always frustrating because there's, of course, never enough funding to support all of the best ideas that come in. We try to support about 20% of them, so about 1 in 5 grants gets funded. I hope that I'm smart enough to pick the best 20%. I'm afraid I'm not, and I think if I could do 30%, I'd probably have a much better hit rate. It's just hard to know often. So that's always the challenge, is you never have the funding you want to do all of the science, some of which is just spectacular, that's sitting there in front of you.
Can I ask you just to expand on that in one more dimension? And that is, if you describe it as your hit rate, if you really hit on some of these studies, on Alzheimer's, on autism, can you just speak briefly about what the financial impact will be on the country?
Well, so we know that in the case of Alzheimer's, that if we can just forestall the dementia by a matter of a year or 2 years, which is certainly, I think, within our grasp as we've gotten a better understanding of how to predict and now looking at ways to intervene, we're talking about billions of dollars that will not have to be spent, which are now going into the care of people with dementia. It really comes down to a question of, do you want to invest early or do you want to pay later? Because you don't know enough and you're not doing this in a way that's efficient. And unfortunately, I think we've tended to decide that we'll pay later, often at a very large premium, instead of making the early investments in Alzheimer's, autism, schizophrenia, to make sure that we come up with better solutions.
Thank you very much. Ms. Hyde, my time has expired, but if you had a quick comment you'd like to add.
The quick comment here is you know, of course, that these disorders have profound impacts on our justice systems, on our school systems, on our public welfare systems, our child welfare systems. There's profound dollars that are being spent there because we are not intervening early, because we are not providing the kind of supports to the young people and their families.
Thank you very much. Thank you, Mr. Chairman.
Mr. Chairman, thank you. I was unfortunately on the floor with my senior senator. There's nothing unfortunate about that, on an issue of great importance to Colorado, so I missed the testimony. I think I'll refrain from asking my questions today, and I'll submit some for the record if that's okay with you. And I know there's a second panel, but I want to thank you very much for holding this hearing, and I'd like to join Senator Frank in saying how delighted I am to see our ranking member, Senator Alexander, here, and thank Senator Enzi also for his work as the ranking member of the committee. And finally, to welcome our new colleagues to the committee. It's wonderful to see you here. Thank you, Mr. Chairman.
Thank you, Senator Bennett. I thank our first panel. Thank you, Dr. Insel. Thank you, Ms. Hyde, for being here. Now we'll call our second panel. Dr. Michael Hogan, Dr. Robert Vero, Mr. George Del Grosso, and Mr. Larry Fricks. Let me see, which one is it? So our next panel, first I'll introduce Michael Hogan. Dr. Hogan, the former commissioner of the New York State Office of Mental Health and chairman of the President's New Freedom Commission on Mental Health. In his capacity as commissioner of the New York State Mental Health Office, he oversaw New York's $5 billion public mental health system. Previously, he served as director of the Ohio Department of Mental Health and commissioner of the Connecticut Department of Mental Health. So we thank you for being here, Dr. Hogan. And for purposes of introduction now, I'll turn to our ranking member, Senator Alexander.
Thanks, Mr. Chairman. I'm delighted to welcome Robert Vero from Center Stone of Tennessee. He's well known in our state. He's done work in the behavioral health care field for a long time, 4 decades. He's chief executive of a company or a nonprofit organization, the largest nonprofit community mental health centers. They have more than 50 facilities, 160 partnership locations. They serve nearly 50,000 people of all ages each year. He has distinguished academic background, which includes his work at Peabody College at Vanderbilt. He's a clinician. He's active and consulted by many for his expertise in this field, and I look forward to his insights about who needs help and how we can do a better job of making sure they get that help. So thank you for being here, Dr. Vero.
Thank you, Senator Alexander. And also for personal introduction, I'll recognize the senator from Colorado, Senator Bennett.
Thank you, Mr. Chairman. It is a great privilege to introduce Mr. George Del Grosso to the committee. Mr. Del Grosso currently serves as the Chief Executive Officer of the Colorado Behavioral Health Care Council. The council is a statewide network comprising 28 behavioral health organizations. It provides treatment and other services to over 120,000 Coloradans each year. Mr. Del Grosso began his career as a psychotherapist. He then became a marriage and family therapist, and he was promoted to a clinical supervisor and program developer before ultimately moving into senior management. Before leading the Colorado Behavioral Health Care Council, Mr. Del Grosso served as the executive director of mental health centers in the San Luis Valley, in our state, and in Cody, Wyoming. Throughout his career, Mr. Del Grosso has worked to improve training and to develop integrated treatment approaches to mental health care. Currently, he's working to expand the mental health first aid program in Colorado to improve prevention, early identification, and access to care for those suffering from mental illness. His decades of experience within the mental health care system give him a unique perspective on our discussions today. And it's in that spirit I'd like to welcome Mr. Del Grosso to the committee, and I look forward to his testimony.
Thank you, Senator Bennett. And now we have also Mr. Larry Fricks, a senior consultant at the National Council for Behavioral Health. Mr. Fricks is also the director of the Appalachian Consultant Group and deputy director of the SAMHSA HRSA Center for Integrated Health Solutions. He will share with us his firsthand account of recovery from mental illness and substance abuse, and we thank you for being here, Mr. Fricks. And again, as with the last panel, your statements will all be made a part of the record in their entirety. And I ask you to sum up. We'll just go down from Dr. Hogan down in 5, 6, 7 minutes or so we can get to a round of questioning. And I'll start with Dr. Hogan, I read all your testimonies last night. They're just excellent, every one of them. I remember, Dr. Hogan, you talked about separate but unequal mental health from what we call regular health, I guess, or the healthcare system. Dr. Hogan, welcome. Please proceed.
Well, thank you, Senator Harkin. And I just have to start, as others have, by expressing appreciation on behalf of our community to the committee for focusing on this time. It's been quite a while, but the timing now, for other reasons that I'll explain, than recent events, I think make it the right time to pay this concern, and we're particularly appreciative that this focus happens on Senator Alexander's first meeting as ranking member. I would start my remarks by focusing on something that is subtle and often not apparent with respect to how mental health care is provided, and that is to say that the mental health system started in asylums run by states without the support or involvement of the federal government anyway. And to some extent, as we focused on a movement from asylum to community, there was attention to the locus of care that was being transformed. But what escaped attention was that care in separate programs and systems was still separate. That is changing before our eyes right now. and it's changing, and it's accelerating in ways that we can't even see because of legislation that has already been discussed, first originating in this chamber with Senator Wellstone and Senator Domenici, to say that mental health care had to be a part of health care, no longer separate. And then second of all, the Affordable Care Act took that parity legislation and baked it into all the changes in health care that are going forward. So we are at a time when mental health care is increasingly going to be part of health care. And this raises two major questions for me. One of them is, will we take time and attention to make sure that we get mental health right in the mainstream of health care? We're fumbling at that right now. I want to talk a little bit more about that. And the second is, as we move away from the separate system, will we pay enough attention to it and ensure that there is sufficient stewardship for it in states and so on? This is primarily a state problem. Or will we recapitulate the institutionalization by walking in another direction that is well-intended but that forgets the people with the most serious needs? Those, it seems to me, are the two major challenges that we face. And having said that, I want to just touch on a couple of points briefly in that context. The first of those has to do with the imperative of trying to figure out how we can help primary care providers to deliver basic mental health care. We're not asking them to do the complicated stuff. But most primary care providers with a little bit of help can do an excellent job with most of the conditions, mental health conditions, that people walk into their offices with, but they can't do it on their own. They've got to have a social worker or a nurse or somebody who can spend the time with people. Their practice has got to be paid a little for that. Medicare still doesn't do that very well. And we have to take steps that are toward what's now called integrated or collaborative care to make sure that we provide that care in primary care. Right now, more people get something for their mental health problems in primary care than get it from the entire separate mental health system. But it tends to be a day late and a dollar short and not to be very effective. Your chances of getting a diagnosis with depression if you walk into your GP's office are less than 50-50, and your chances of getting enough treatment to make a difference are about 15%. But with a little bit of attention, that problem can be resolved. I won't comment too much on the problem of protecting the safety net as we go forward in this transition, but I think what I would say is what the committee's attention might be focused on is whether there are adequate standards for mental health care, not in SAMHSA, but in CMS as the system goes forward. Increasingly in states right now, when you're concerned about mental health, you don't talk to the mental health director, you talk to the Medicaid director. And whether they have this on their radar screen is sort of a coin flip. And federal standards there would help. The committee has already talked significantly about children's issues, and Senator Alexander's example of that 17-year-old with an early psychotic symptom that Senator Murkowski also talked about is something else that I want to comment on. We know how to address those problems today, and we do not. We know how to engage people in care with an early psychotic problem, as we would, in a sense, in a modern cancer center. Family would be welcome. We look at a longitudinal plan of care. We would stick with people to try to find something that was acceptable to them, as opposed to waiting till they deteriorate, putting in a hospital, letting them leave with a referral to care that is just not going to work. And I have two other points that I've addressed in my written testimony, and my time is up, so I won't comment on them, other than to say I really want to underline what Senator Murkowski has said about the problem of suicide. The Administrator Hyde and the Surgeon General have really stepped up on this. The Department of Defense and Veterans Affairs are moving on this. The rest of the government should pay a little bit more attention, because it's costing us more lives lost from suicide every week than we lost to military suicides in the entire last year. Thank you.
Thank you very much, Dr. Hogan. And now we turn to Dr. Vero.
Thank you, Senator Harkin. Thank you, Senator Alexander. On behalf of Senator Stone and my colleagues in behavioral health throughout this country, I again want to echo how much we appreciate the attention that community behavioral health and mental health care in general is receiving as a part of this hearing. You know, I hope that what I share will assist this committee truly as you seek to gain an understanding of the opportunities to address the gaps and barriers that we know currently exist in the mental health system. It's been echoed several times this morning that we know recently our country absolutely suffered the devastating loss of 28 precious lives, 20 innocents, 6 courageous teachers and administrators, a mentally ill young man who did not get the care that he needed, and his mother who did not get the care nor the information that she needed. This tragedy, along with those in Colorado, Arizona, California, Virginia, and others, have thrown a very invaluable spotlight on community mental health, mental illness, in this entire discussion. You know, to work in this area of community mental health is an extraordinary privilege. It's likewise a tremendous responsibility. I've been fortunate throughout the last 4 decades to participate in our field from a variety of perspectives as a clinician, as a critical incident responder, as a faculty member, as a research collaborator, as a patient, and as a CEO. I've seen firsthand what the research shows. Mental illness affects everyone, and mental health treatment is effective. Community mental health centers do a tremendous job for the people we serve. We change and save lives, helping to build strong, healthy, resilient individuals and strong, healthy, resilient communities. There are, however, several significant barriers and gaps in the current U.S. mental health system that makes it difficult for our local agencies to serve the safety net they were intended to serve by President Kennedy more than 50 years ago. Most significant among these is the limited availability of quality mental health services for children and youth. Sadly, we lack a federal definition of what services a community mental health center should offer. Consequently, many towns and cities, especially rural ones, do not have access to a continuum of care that covers the lifespan. Since 50% of mental illnesses do occur before the age of 14, and 3 out of 4 people experience the initial onset of these illnesses by the time they reach young adulthood, the lack of early intervention can have tragic and lasting effects. Congress is encouraged to pass language similar to that included within the Excellence in Mental Health Act, defining that a community behavioral health provider must provide a full continuum of services across the lifespan. In particular, we wish to thank Senator Debbie Stabenow and Senator Jack Reed for their tireless leadership in this critical legislation. There are several ways as well to address the barriers to providing quality children's services. Thanks to grant funding from SAMHSA and the Department of Education, Centerstone has been able to deliver home and school-based services within both urban and rural areas. These programs have proven clinically effective and likewise offset overall educational costs. Congress could increase its support of federal funding to effectively deliver prevention and early education services. Congress could ensure as well that services to children and youth target the entire family. Research shows that programs that engage the whole family are the most effective programs. Inadequate insurance coverage too often becomes the barrier to engaging the entire family. Incredibly, not all states, counties, and community mental health centers offer formal crisis services, especially those services that are delivered 7 days a week, 24 hours a day, 365 days a year. The Excellence in Mental Health Act would also require the provision of these crisis services. Technology, which we haven't talked very much about this morning, also prevents another barrier. Thanks to the work of the Office of the National Coordinator of Health IT and the leadership of Senator Shelton Whitehouse, there have been tremendous advances toward creating standardized communication guidelines. Unfortunately, since community mental health was left out of the 2009 HITECH Act, we have not been able to fully benefit from these advances. Strong bipartisan bills in both houses of Congress, like those that have been introduced in the prior Congress by Representatives Murphy, Blackburn, and Senators Whitehouse and Collins, would correct this problem. With behavioral health IT, this is what community behavioral health would be able to do. We could effectively share information for purposes of coordination of care, including treatment plans with primary care providers. We would prevent some of the drug-drug interactions that occur because of a lack of shared information and hopefully prevent overprescribing. We could also effectively track outcomes over time. There's a great need for integrating physical and behavioral health care in this nation. We hear a lot about America's fragmented and broken health care system. The consequence, at best, is costly, and at worst, dangerous and too often deadly. People with serious mental illness, on average, die 25 years earlier than their non-mentally ill contemporaries. Is it because of their mental illness? No, it's because of the impact of their comorbid conditions, diabetes, cardiovascular diseases as examples. Community mental health centers are key to improving physical health care by simultaneously lowering overall health care costs. Our expertise in behavior change is part of the solution to meet the triple aim of health care: reduce cost, improved health, and quality outcomes. We are grateful that in 2009, SAMHSA launched its primary care and behavioral health integrated care program, and since has launched 94 programs across the country. 2 have happened to land at Centerstone, which we're very fortunate. The SAMHSA initiative seeks to improve the physical health status of people with serious mental illness and reduce their total health care costs by making sure services for behavioral health and physical health are provided at the same location. We have a substantial and complex task before us. We cannot solve these issues alone as providers. This is a moment. This is a watershed moment that demands courage and action. Everyone in this room shares responsibility for the future of community mental health. Community mental health centers stand ready to work with you, our elected and representative officials, to make a difference in this U.S. mental health care system. Thank you.
Thank you very much, Dr. Vero. Appreciate that. Now, Mr. Del Grosso, welcome. Please proceed.
Thank you, Senators Alexander and Harkin, and you, Senator Bennett, you've always been there for us for mental health in our state. I want to thank you for being there. It's interesting this morning as I hear the discussions happening around the room, and I want to share 2 thoughts with you, if I might. The first one is, I think you may be surprised about how many people are watching C-SPAN today from around the country because they're so excited about the opportunity to really discuss this matter in the kind of detail that we're really hoping for. The second part of it is, I'd like to share with you that if I could take a video of today and the comments that you all were making up there and comments made down here today, and if we could sort of encapsulate it and play it to the public, and if that became the public message, we wouldn't have to be here today. And I think people would be greatly moved by what all was brought here today and what you're saying about our area of health care and how important it is to address it, both mental health and substance use disorder. Today, I've been asked to talk about mental health first aid. There were several of you that said, tell us about what we might be able to do to intervene or to connect earlier, and that's what I'll be sharing. But I wanted to make sure, so I don't run out of time, to tell you that there are a couple of things that can be done. One is that with the shortage of funding that has been in the area of mental health and substance use disorder, that funding that is available has really been focused on people who already have diagnosable conditions or are already significantly ill. And we need to ensure that we continue to provide care in those areas. But what we're having problems with is when we do start doing prevention work in both the physical health area and the behavioral health area, often the codes and the funding are not available. And so you have to take it out of your own pocket, in a sense, as a provider or the person themselves, to try to get some of the necessary prevention and early intervention services and supports that they need to keep them from getting to that point. And this is particularly a problem in the area of Medicare. And today we haven't talked very much about the elderly. And I think a lot of people think because somebody's getting old that they're going to just naturally be depressed and it's a bad thing. But you know, that's really not the reality. Many people are aging and doing well, but sometimes there is depression or have substance abuse disorders just like anybody else. And they need the help and the care that they can get to be preventive and also to get the treatment. Mental health first aid is an area in our state that we have a great deal of excitement about, because of a couple different reasons. Number one is that we saw the opportunity with mental health first aid to really get out into our citizenry and to be able to talk about mental health itself and increase their literacy and their understanding and recognition of the signs and symptoms of common mental health diseases like bipolar, major depression, PTSD, and anxiety disorders, as well as substance use disorders. But it also provides a crisis escalation, de-escalation techniques by the people who take the class. Just like physical health, first aid helps you in order to be able to bandage something or to splint if there's a broken leg. And then there's a 5-step action plan to get persons in psychiatric distress referred to mental health providers. It's a very comprehensive program. In the wake of the serious summer that we had, we often know about Aurora and the shootings that are there, but we also had 2 major fires in our state this past year that a lot of people lost their homes. There was some loss of life, and it was one of the most depressing summers we've had in Colorado for a long time, and it's a beautiful state to live in. And one of the things that we found is that by using mental health first aid, a lot of people began reaching out more for help themselves and to help their family members, but to understand more about what's going on with them and what's happening in the world around them. I'll never forget meeting one day with Senator Udall and Senator Bennett and talking about the issues around mental health, and Senator Udall looked up and said, what we need is a program to help us to sort of identify things for our family members and friends and in our churches and in our government, etc., when they need help. And we said, sir, let us tell you about mental health first aid. And at that point, it became a real charge for us in Colorado. It's interesting to note that our mental health first aid instructors have also done training with the governor's cabinet, department heads, and mental managers at many state agencies. And there is a consideration right now that all state agency or state employees will take mental health first aid. The Department of Corrections does this today, and they have trainers, and all of their corrections officers are being trained. I can go on and on about the number of people who have received this, but I want to let you know that there's some really great news coming out of Washington on this. That last week, Representative Ron Barber introduced the Mental Health Aid Act of 2013. That's H.R. 274. And this is, as you may know, he was wounded in the tragic incident in Tucson, and mental health first aid was also helpful in their area as they were recovering from their tragedy there. And we have it on good authority that there is going to anticipate that there's going to be a bill with bipartisan support coming through the Senate. And we would really ask that you consider supporting this as a committee and providing the funding that we so necessarily need in our community. Again, I want to thank you so much. What a tremendous opportunity to be here today and speak on behalf of this area of health care. Thanks for your interest.
Thank you, Mr. Del Grosso. And now we turn to Mr. Fricks. Welcome, and please proceed, Mr. Fricks.
Thank you, Chairman Harkin and Senator Alexander. It's an honor to be here, and an honor that we're getting this sort of focus on those of us that experience mental illness and addiction. I'd like to address 3 topics today. First, the stigma and discrimination that surround behavioral health disorders. Second, the critical role of peer support and a new workforce in our country called peer specialists that promote recovery. And third, the importance of whole health. Senator Harkin, mind, body has been huge in my recovery from bipolar illness. So those are the 3 topics I'd like to address. First of all, I am someone who recovered from bipolar illness. I'm also clean and sober 28 years. And I can tell you, and my peers can tell you, that we fight 2 battles. We fight the illness, but we also fight the stigma. And we have a saying in our movement, what you believe about mental illness may be more disabling than the illness itself. And yet as a society, we largely remain ignorant about the signs and symptoms of mental illness, and we ignore our role as supportive community members to help those of us experiencing those illnesses. I was hospitalized 3 times in the mid-'80s. I fall in the category of a serious mental illness. I've ridden in the back of a deputy's car. It's a very humiliating experience. I spent a day in jail because of my psychosis until family and friends intervened and got me help. And I attempted suicide. So you can see it is humbling to be here today and have a chance to talk about this. I mean, what happens is the stigma is so significant that we often internalize it. It takes over our lives. It's not only the diagnosis, it becomes the prognosis that your life is over as you've known it. And yet today, I live a full and meaningful life. I have a wonderful wife and a life in the North Georgia mountains. Key to that was learning self-management skills. I haven't heard anything about self-management. Those of us in recovery, we know about self-management to stay well. Peer support is huge. Having somebody that you can relate to, and also receiving services. Now the future is mind-body. I just want to say that learning about sleep deprivation and its role in bipolar illness was huge for my recovery. And it was a former director of NIMH, Dr. Fred Goodwin, that introduced me to that. And I managed my bipolar illness largely by managing my sleep patterns. Be very careful. I fly almost every week, and I'm very careful. And so this new workforce of certified peer specialists. In Georgia, for 13 years, I served on the management team for the State Department of Behavioral Health and Developmental Disabilities. They're the fastest growing workforce in our state. We've trained nearly 1,000. There's probably been 12,000 trained across the country. We focus on what we call strength-based recovery and whole health. We're able to deliver services that are Medicaid billable if the service is included in the state plan. And research on the effectiveness of peer specialists has been so positive that in 2007, the Centers for Medicare and Medicaid Services issued guidelines for states wanting to bill for peer support services, proclaiming them as an evidence-based model of care. So, and then research shows that we have a unique ability as peer specialists to connect with other peers, to ignite hope and teach skills for recovery, self-management, and promoting whole health. However, I would warn you that Medicaid's focus on medical necessity makes it tough because we are strength-based and we look at unlocking hope and managing self-management, so it's a little tough to fund under medical necessity. So we'd like to see more flexible funding for that. Peer respite centers are springing up across the country, staffed by us. If you're feeling early warning signs, you can go in. In Georgia, we have 3 of them in Georgia. You can spend up to 7 nights surrounded by peers, and it's keeping people out of hospitals. We're having tremendous success in Georgia. We're under a Department of Justice settlement for deaths in our hospitals, so this is a service that we have that's really starting to pay off. And then addressing this mind-body health care, there can be no health without mental health. Conversely, we cannot successfully care for people with mental health and addiction disorders without addressing their co-occurring physical health disorders. Research indicates that people with severe mental illness in the U.S. who are served in the public health care system have an average life expectancy that is 25 years less than the general public. We've heard that already. We're dying early 50s, many of us. So I just want to thank SAMHSA. They're working to address this by providing grants to community behavioral health centers for offering basic primary care screenings and coordinating referrals to primary care. As part of the primary care behavioral health integration program, nurses, trained care managers, peer specialists, and other healthcare professionals are now actively working in 94 grantee sites to screen patients for weight gain, blood lipid levels, cholesterol, teach skills for whole health self-management, and more. And although data is still being collected, early results indicate that this program has been successful, is helping people with behavioral health conditions maintain or reduce their weight, cholesterol, blood sugar, and other risk factors for chronic disease. And I strongly urge the committee to support this important grant program. And in closing, I'd like to say that after nearly 3 decades of experience in behavioral health, it's taught me that the greatest potential for promoting recovery and whole health comes from within the individual. And with the support of peers, family, and community, and my recommendation is to establish and support programs that drive this potential, putting the person at the center of all services, building on their strengths and supports. Thank you very much.
Well, thank you, Mr. Fricks. I think your testimony really does kind of summarize what we're all here about here today, and that is providing the kind of interventions and early supports so that people can successfully deal with an illness, just like we deal with every other illness. And you're a prime example of that. And from my limited experience in this area, I couldn't agree with you more that the most important element in this comes from within. And how do we build that system? Peer supports, so important. You talked about maybe billable hours for providers of peer supports. I can tell you that it's so extremely important. That self-management skills need to be taught. A lot of times this doesn't come from just a drug. And I think it also recognizes, and I kind of get back to Dr. Vero on this also, that mental health and physical health are, as you said, intricately intertwined. Now, again, at the risk of practicing medicine without a license, but I've been involved in this for almost 30 years now, from this standpoint, this committee and my other committee, that I think we have more than adequate data to show that so many physiological conditions have their genesis in psychological conditions. And yet we always attempt to just treat the physiological condition. And sometimes that makes it even worse. We had a hearing on this last year on pain. And all the pain clinics that have come up all over America, they're treating pain. Yet we had one witness, a very distinguished doctor, written a lot of books about this, so that not everything, you can't make everything just total, but for the vast majority of these pain afflictions, it has its genesis within psychological problems, anxiety, stress, things like that manifest itself in pain. Yet people go to pain clinics to get a shot or to get some kind of medicine or to get a back operation or something like that may not be warranted. And again, I'm always cautious to say that it's not 100%. I'm just saying that the vast majority of this, and I just don't think we recognize that. And this intricately intertwined between mental health and physical health. Well, I took a lot of my time talking, and I shouldn't. But I wanted to start with Dr. Hogan. You talked about getting it right. Primary care providers providing mental health care, moving from a separate system. Tell me about the accountable care organizations now that are springing up. They're going to have the guidelines, you see, for what these entities have to provide. But I don't think we have any kind of instructions to them. And is that what you're suggesting, is that we need to instruct these accountable care organizations that they also need to structure this? They need to structure it.
Absolutely. And they'll learn this sooner or later.
Well, we can't wait a little.
Exactly. So, for example, if you have diabetes or hypertension or cancer or these other major medical problems, and you also have depression, your total medical costs are going to go up somewhere between 50 and 75%. And if you treat the depression, it allows the person, as Larry was saying, to be an active player in the management of their whole health. Mm-hmm. And so, but you can't hope that the depression goes away. You actually have to diagnose it. You have to provide a little treatment for it. But the data shows that a relatively small investment in providing that mental health care in that primary care setting, or it might be in the context of an ACO, is going to reduce total costs because people are going to be better able to take care of themselves.
Now, Dr. Bureau, you mentioned that also in your testimony about the affordable care, for accountable care organizations. Do you have any elaboration on what Dr. Hogan just said?
I think the other element at play would be our expectations for accountability. So let's underscore that. That act will allow us to set some clear expectations for performance. What's expected in terms of improving those health care outcomes. And the agreement between those accountable care organizations and the provider in that provider system, we are now beginning to target what are those key healthcare indicators on the physical health side, on the behavioral health side, that will work together to truly improve overall outcomes.
There's a barrier of insurance coverage. I think you mentioned that. In this area around the Washington, D.C. area, there are very few in-network mental health providers. Well, I got to looking at that some time ago and wondering why. I got good coverage, Blue Cross, Blue Shield, and all that, but I'm amazed at how few are in the network. The more I looked at it, they said, well, the reimbursement's not good enough. Well, I looked at that a little bit longer, and then I started thinking and looking at the amount of support that taxpayers, through federal programs and other programs, gave these practitioners when they were going through medical school, or when they were then going into their specialties, and then when they were going into their residencies. Now, to be sure, a lot of them accumulated a lot of debt themselves that they're paying back, but again, they got these nice guaranteed government loans at low interest rates. And so I'm just wondering, shouldn't we expect a little more of them than that they just don't get reimbursed enough by Blue Cross Blue Shield, so they're out of network? And so again, as I think Senator Sanders said, if you have the money and you can afford it, you're fine. But you could be actually paying a lot in your insurance coverage, still not having the coverage for mental health services, and then you got to pay additional out-of-pocket for that. Any thoughts on that, Mr. Del Grosso?
Yes, sir. Thank you so much for making that comment, because it's something that's what they say, the proverbial elephant that's in the room that people don't often talk about. And it's been sort of surprising to me how insurance companies have not been able to somehow put together the savings on the physical health side if they provide more care on the behavioral health side. And it may be due to the fact that they've got short-term contracts and don't necessarily look at the long run with it or whatever. But I think that what we see is this brain or the head is not connected to the body, and sometimes often is the management and the thinking as people go forward. And so they look at the physical health costs separately from the behavioral health costs. And one of the real pluses for accountable care organizations that you were talking about is the opportunity to bring together the funding to put the right service, the right place, the right time, and the right cost or right payment that might be there. And it brings all four of those pieces together, where if you're saving money on the physical health side by providing more behavioral health services, you can move that money over there as needed, and vice versa. So it's really important. And I think the expectation of providing care for people who are uninsured, that has fallen greatly on the federal government and on our states in their indigent care programs and in your Medicaid program. So people end up shifting over to the public side because they don't have the physical health, the behavioral health coverage on the physical health side. It's really, it's a quagmire. But I think that we're on the verge of making some changes that could be very helpful for us.
I just told my staff what you said. We got to work on this. We got to make sure these accountable care organizations have that model, and that they fully implement that model. And hopefully we can, through this committee and through the administration and others, impress upon them the necessity of doing so. Well, thank you. I've run way over my time, and I apologize. Senator Alexander.
That was very interesting. Thank you, Mr. Chairman. Well, thanks to the four of you for coming today. And I'd like to listen to what you have to say, so I'll ask a question that I'll ask each of you to answer. If you could think of one thing that the federal government, that we could do to make it easier for you to spend the money we now spend more effectively, the money we spend primarily through the two big block grants and through Medicaid is the way I gather it's most of the federal money it goes to mental health. what would be the one thing that we could do that might make it easier for you to do that? And Dr. Vero, if you could start, and I'd like to ask you this additional question. You mentioned about the importance of a continuum, which makes sense for a community mental health center. Now, you're one of the largest operators of community mental health centers. Would that be an additional cost to each community mental health center if it did that? And if so, who'd pay for that? Would that, if the federal government were to require that, how much would it cost and how much money would we have to appropriate for that? Or if we require it without paying for it, which is sometimes what we do around here, then who would pay for it?
Senator, I want to first start with an acknowledgement of my early service in Tennessee and you in your governor role. We talk about this continuum of care over the age span. When you were governor of Tennessee, we built out a statewide therapeutic preschool program. We had therapeutic preschools in every single one of our community mental health centers across all 95 counties. Those schools were there to deal with their most vulnerable children with whom we were seeing early indications of the onset of severe mental illnesses. Those SCD children we've referenced several times today. So what happened? Very few of those programs exist. And I can tell you we are so fortunate at Centerstone to still continue that program, but it's not in the four-wall classroom any longer because that model was no longer affordable. Community mental health care has been subjected to a horrid state of commoditization. It's just a fact. As we move from Medicaid programs to managed Medicaid programs, we are part of the healthcare system that continues to be looked at as a commodity. Our services are minimized oftentimes to their smallest view, to the nickel, to the dollar, to the quarter, to the nickel for differences in choosing who the provider might be, where the contract is, more importantly, what the service is, what that array of services are. So as that requirement dropped with that commoditization, those preschool programs were lost. We took our preschool program and moved it into the community. And here's the good news. We were only able to serve about 48 of those children a year because it was a high-cost program and because the managed care company had a hard time understanding what its role was in addressing the health care needs of these children while they were also receiving vital educational services. So one of the things we need to do from that federal level is let's remove these barriers that oftentimes don't allow us to bring our systems together, education, criminal justice, mental health, in a cooperative way for the sole purpose of addressing our health care crisis. We spent too long arguing over what part of the day education should pay for versus what part of the day the managed care company or Medicaid should be paying for. We have to address those conversations immediately if we're going to make any difference in the conversation that we're having today.
That would be, I'd like to work with you, and I'll ask my staff to follow up to get specific examples how to do that. Just out of curiosity, was that part of the Healthy Children Initiative that we had initially back then?
Yes, sir.
Well, I'll tell my wife.
She'll be, yeah.
That was 30 years ago. So we have my wife was the head of that, and the deputy of that was Marguerite Salih, who later, who runs America's Promise until recently, and headed Bright Horizons, the worksite daycare company. Now, my time's about up, but if there's one thing that we could do that would change existing law or practice to spend the money we now spend better, and you can follow that up in writing if you'd like to. Is there one thing you'd like to briefly mention? And that's my last question.
I'd like to make a recommendation that you allow that the services that you currently pay for could be opened up to provide more services at the front end, to provide more prevention, early intervention, support peer services like what Larry was talking about a little while ago, and to let the creativity of this country and how we're moving forward in other areas of health care to also enter into behavioral health care and allow us to do the right thing.
Thank you. Was there any other comment on that?
Any other comment on this?
Yes, Senator, if I could add to that, we keep talking about access. We've talked about the shortage of psychiatrists, especially child and adolescent psychiatrists. We've been providing telepsychiatry services since 2002 in the state of Tennessee. Those services are getting out to counties where we can't hire physicians, where we can't draw those physicians to maybe those more rural areas. It is 2014 as we sit here today. We need to align our payment streams with our current technology. We're not permitted in the state of Tennessee, and I know elsewhere throughout the country, to provide telecounseling services. I can provide telepsychiatry. I can have a psychiatrist talk to a child and interview that child and provide services and work alongside a practitioner who's sitting next to a child and do medication management. But I can't provide counseling services remotely through telehealth and get reimbursed. It's 2014. We have 12 years of experience on the psychiatry side, and we can't seem to move out of the current limitations around those services.
Thank you, Mr. Chairman. Thank you, Senator Alexander. Senator Franken.
Thank you, Mr. Chairman. Thank you all for your testimony. Dr. Vero, you note in your written testimony that there are a number of barriers to access to children's mental health services. Specifically, you recommend, quote, grant funding streams that encourage existing centers to expand their service continuum and partner with community organizations. I mentioned in the earlier questioning that I'm introducing a bill called the Mental Health in Schools Act, which does that exactly. By providing grant funds for schools to partner with mental health centers and other community-based organizations. Can you explain why this is so important to students?
And Senator, first let me thank you for moving that bill forward again this year. I think it's rather simple. You know, we know that most of the disorders that we see in children are first identified, not as most of us would believe in the office of a pediatrician or their family practitioner, but instead by their school teachers. Some as early as their preschool teachers who see this behavior. You know, they're well trained in normal child development. They typically know what is expected of that age group. When they see unusual and bizarre behaviors or very, very troubled children, they need to bring that to the attention of professionals. Your bill is encouraging the same thing. Those teachers have the competencies to help us identify those children who need early intervention. We're in 160 schools currently in Tennessee. Those are partnerships that work. I have licensed master's level therapists in those schools providing the care that you're outlining, that you're addressing. We need to get school-based services throughout the country.
I was just in Mounds View, Minnesota. We had a roundtable there, a couple roundtables, but one on specifically on this, on integrating the schools with community mental health. And you talk in your testimony also about how this is really a family disease or a family matter. We had 3 mothers testify whose kids were turned around completely to the good. A woman who, because the school system had integrated this system with community health, and they had a mental health partner, professional who took their case, a caseload of a number of people. We had one woman there, I think she was 26. She had an 8-year-old child who had been completely turned around, 3-year-old child. She was a single mom. She was not, a wealthy woman living on Fifth Avenue. This woman had such joy in describing her son, who had been completely turned around. He was diagnosed, I think, with Asperger's, and he had been unruly, but once they got a hold of it, he's turned around completely. And we had 2 other moms there. This is a family disease.
It is.
I wrote 2 movies in like 20 years ago on the family disease of alcoholism. And thank you, Mr. Fricks, for your testimony. Congratulations on 28 years of sobriety. When I was doing research for that, I was talking a lot to rehab counselors. And Mr. Hogan, Dr. Hogan, I want to ask you about this. The shocking ignorance of general practitioners about alcoholism. When you talk about this, the teacher is for kids in the school, but the pediatricians, what they don't know about this is pretty remarkable. And integrated care is so important, and it's something we do pretty well in Minnesota. And we have accountable care organizations that were already accountable care organizations before we wrote accountable care organizations into ACA, and they've become a pioneer ACOs. What can you say about the training of doctors in medical school that we should be doing that we're not doing, or have we gotten better at that?
Thank you, Senator. I want to just comment very briefly on your point about children, and to underline this in a way that I think may resonate with Senator Harkin, because he's been closely connected to and has followed and helped build an extraordinary national program of early intervention for young people who have got a developmental disability. If you have got a significant developmental disability, you're basically entitled to some support and care for yourself and your family. For children with these problems that you're describing, and that 8-year-old who you described got turned around, we have an average wait of 9 years until we find out about it. And these are conditions where just a little bit of help is going to change that young man's trajectory possibly for the rest of his life. So this is of profound importance. And I'll say 2 things with respect to your question around doctors and their training. And one is that the training around these conditions is, that there's too much that they have to cover in medical school, and this gets short shrift, period. But it's not a problem that can be fixed by training doctors better, because the primary care doc has got 7 or 8 or 10 minutes. So the only way that this integrated care can be delivered is if, one of our types is basically parachuted into that doctor practice. And if the patient does a screen in the waiting room, and the doctor can then say, I see you have concerns about you're sleeping and you're feeling depressed, and I'd like to ask Mrs. Jones to come in. She's an expert in that area. Mrs. Jones can then spend the time that it takes to talk through the symptoms, to maybe explain the sleep issue that Larry described. So these programs that go under a rubric of collaborative care, the doctor does have to change behavior a little bit, but it's got to be a team approach. And the team approach can be thwarted by 2 things. One is, if we take the mental health benefit, I'm going to argue in a way that may seem reverse. If we keep the mental health benefit in the Shepherd insurance plan and only pay it to mental health specialists, it's not going to help the primary care doctor. But if we give it to the mainstream insurance plan and don't make them, measure it, did you ask about depression? Did you start people on treatment? Did they improve? Unless we do that, we can't expect results either. So we're sort of getting what we have designed. So I'm going to say that parity, as important as it is I think less critical now than figuring out how to crack this problem of primary care and getting support to the doctors out there that have got 8 minutes, don't have the training, and don't know how to do this stuff.
Okay, I would just argue that when these conditions, these mental health conditions, these addiction conditions, somatize themselves into other things, and that I see a lot of nodding, that there are primary care physicians who don't understand that, and don't understand that they're seeing something that is really comes from something else, and something else that may be addiction or maybe mental health. I'm way over my time. Thank you, Mr. Chairman.
Thank you, Senator. Senator Warren.
Thank you, Mr. Chairman, and thank you all for being here today. I read your testimony, all of it. It was Very powerful testimony. Thank you very much. The thing I drew out of the testimony, though, is a part we haven't talked about, and that is that millions of people who have serious mental health issues are not seeking care. And you've talked in different ways about why that is so. You're all kind of describing a different part of the animal that Mr. Fricks talks about stigma and why people don't ask for care. We talk about the availability of treatment, practitioners, whether or not we've got enough people, how we might deal with that with peer specialists, how we might deal with that with community health care centers, in doctors' offices. We've talked a little bit in the earlier panel about research, the importance of research so we get better treatment, how we get better outcomes at lower cost. But the one I wanted to focus on in this last opportunity to talk is about the cost to the individual. I saw the Kaiser study that 45% of those who don't seek care indicate that the cost is what deters them, that all those other things are there, but they feel like they can't afford it, they can't go out of pocket. And so what I'd like to hear from you is about the impact, about what that means when people deny care to themselves, to their children, to spouses, others in their families, and just what happens then. And to describe that, either we can talk about it in human terms, we can talk about it in financial terms, and in financial terms for the family or for the whole system. So I'd be grateful if you'd talk about that. Maybe, Mr. Fricks, maybe you'd like to start.
Well, in rural communities like mine, it's so obvious about the stigma because you'll park out front if you go into the public health, but if you got to go to mental health, you try to park around back. And so it's just you don't want your neighbors seeing you going into community mental health. So when we integrate, we'll help fix that. Everybody can go through the same door and park in the same parking lot. But it's hard to explain the devastation that occurs from the stigma and the active discrimination. It goes beyond just stigma. We are, of all disability groups, we're the least employed in the country. It bumps 90%. By the way, employment is a huge factor in our recovery. People that have meaningful work. Housing, we're discriminated against. So it's really a lot of it it's almost a civil rights issue. It's a human rights issue. And I am hopeful that integration helps that. And then families are really torn apart by it, too. I'm very fortunate to have had a very supportive family. But the stress and strain economically will bust up marriages. It's just a fact. And so, you're right on it. And so thanks for your acknowledgement of that.
Thank you. Thank you. Mr. Del Grasso?
Larry, thanks. You say it so well. I just think it's interesting that families would not hesitate to get a family member help for an appendicitis or any other kind of physical health problem that they have, but often have a very difficult time reaching out to get the physical or the behavioral health and the substance use disorder treatment that they need. And the bottom line is it's often seen as that you have a character problem or you've got a bad mom and dad or something along those lines, rather than the fact for many people it's they have a brain disease. There's a lot of education yet still to come, and a lot of support that we need at several levels for people to be able to move forward and raise their hand to come out and get help. I can also say, as a mental health provider all these years, that we need to stick our head up a little bit too and be proud of the fact of the area of health care that we provide care in, and that we're not an enigma. Let's take the cloak off of this and let's talk about it, what it really is, and how people can recover and become remarkable members of our community.
Good. With the chairman's indulgence, could I ask Dr. Vero to add your comments briefly on Dr. Hogan?
Senator, thank you for the question. And I'll answer it, I think, from maybe both the human side and the financial side. We can't afford not to treat these illnesses that we identify, especially those that we identify early. They simply get worse. Mental illness is a systemic family disease. And we know that when we look at addiction disorders, in particular alcohol, there may be one individual in that family with an alcohol addiction. That entire family can pick up signs and symptoms of that illness, and there's dysfunction throughout that family. Those same things often occur with people who have severe and persistent mental illness. Mental illness is the leading cause of disability in the United States. Mm-hmm. That cost alone should alarm us all. And we have to start treating this on the front end and not treating it with disability payments.
Thank you. Thank you.
And I'll conclude on that same point. At some point in the last 10 years, the total cost to society of mental illness passed the total cost of cancer and is running second to heart disease. But what is striking about those statistics is that while the cost of cancer and heart disease are the cost of providing care, the cost of mental illness is essentially the cost of not providing care. It's the cost of years lost of life due to suicide, of people not being able to function fully at work, of children not graduating because they weren't able to sit in their seat long enough, and then it escalated, and then they dropped out in high school. So if we could reverse this just a little bit and provide effective treatments, maybe we could slip back from number 2 to number 3 again.
Mm-hmm. Thank you very much. Thank you, Mr. Chairman.
Thank you, Senator Warren. Well, I just want to thank this panel very, very much, both for the work you do and for the testimony you've offered here today. Again, there was a reason why we wanted to start off this Congress, and why I wanted to start off this Congress with this kind of hearing in this committee was simply for the reasons that many of you expressed in one way or the other. And that is, we can't really get a handle on a healthcare system in America until we get a handle on integrating mental health with physical health. And I would lean a little bit more towards Mr. Frick's side on looking at this mind-body connection. And I know, Dr. Hogan, I appreciate that not every primary care practitioner, they've got 8 or 9, 10 minutes. They've got to remember a lot of stuff from medical school and their residency training. But it does seem to me that systems have to be built where you have a collaboration. I have seen these. Yes. They're around the country, where if you go in and you have hopefully electronic records and you have some ailment that you've come in to see a primary care practitioner about, whether it's in a community health center or someplace else, private practice, that there's a collaboration with the primary care physician, maybe a physical therapist, a psychiatrist or psychologist, or maybe both, to take a look. What really is affecting this person? Is it a physical ailment that requires some physical intervention, or is it a physical ailment that's been manifested because of a psychological problem that needs to be attended to? Or is it something else that needs, is this something where a qualified therapist could work with them and their family to take care of, rather than thinking there has to be some prescription for some medicine filled out to go to the drugstore to get? So it just seems to me as we're moving ahead with this Affordable Care Act and this new regime, with all the exchanges and everything, we have an opportunity, I hope, and with the expansion of the community health centers around America. And that's where, Dr. Vero, we're going to be in touch with you more about what you've done in Tennessee, because I think there's a model there for what we're going to do with community health centers in the future and how they're integrated into this system. So that's why I think this hearing is so important, because you, Dr. Hogan, just said that the cost of mental illness now outstripped the cost of cancer in our country, and yet we just don't pay attention to it. So hopefully this will set the stage for a lot of good bipartisan work and integration here of this committee looking at what we need to do to provide this sort of new integrated model in this new health care regime that we seem to be embarked upon here sometime in the near future. So I thank you very much, and we will, I am certain, our staffs or us will be in touch with you as we move along here for further enlightenment and further suggestions and recommendations that you might have. Oh yes, certainly, Senator Alexander.
I want to thank Senator Harkin for this, and I want to thank the witnesses for coming. You made some very useful suggestions, and I look forward to following up. If I may say it this way, this is a committee on which we can have some fairly profound differences of opinion when we're talking about new laws, new spending, new policies. But it seems to me that a lot of what we fail to do here in the federal government is look at what we're already doing and ask people who are doing it, how can we take the programs that we've got and the money that we've got and make it easier for you to do what you need to do? And you've given us a long list of things today that you have suggested that would improve your ability to identify who needs help and identify the person to provide the help. So while we may argue about some things, there's no need to argue about those things. We can work together on those things, and I would look forward very much to that opportunity, and I'll look forward to your specific suggestions about the laws, regulations, and practices that you think we ought to change. And I'll work with Senator Harkin and see if we can do this in a bipartisan way.
Well, thank you very much, Senator Alexander. Thank you. I request that the record remain open for 10 days for members to submit statements and submit additional questions for the record. With that, again, thank you all very much. The committee will stand adjourned.
But we have a long way to go, and we can do better. Thank you for your time today, and I'd be very pleased to answer any questions that you may have.
Thank you very much, Dr. Hyde. And now we'll turn to Dr. Insel. Please welcome again, and please proceed.
Thank you, Mr. Chairman and Ranking Member Alexander and members of the committee. It's a real honor to be here, and it's actually a great pairing to have Administrator Hyde and me on the same panel. This is essentially going from services to science. So as a person coming to you from the National Institute of Mental Health and the National Institutes of Health, my role is really around the research related to mental illness and thinking about how to come up with the science that will lead to better diagnostics, better therapeutics, better understanding of what you called a silent epidemic, Senator Harkin, and that's actually an interesting term for this. I know we haven't met for some years to talk about this, so it's particularly for us important to get this out on the agenda. It's clear that in some ways this is a response to this tragic event that happened in December in Newtown, Connecticut, and if it takes an event like that to focus the nation's attention on the needs of those with mental illness, it's terrible to say that, but at least perhaps one of the opportunities that can be taken now is to think about how do we do better by those with mental illness and how do we make sure that events like this don't happen again. I'm not going to read my testimony, and to save time, I think both Pam and I are eager to get to your questions. But perhaps to preempt some of those questions, let me take just a couple of minutes to make some of the points that might help in terms of how we think about mental illnesses, some of the definitions and the science as we understand it. First of all, when we talk about mental illness, we're talking about, as you have already heard, very common disorders: depression, PTSD, eating disorders, and there are many others. There are about 10 or 12 that we focus on. These are real illnesses with real treatments and affect about 1 in 5 Americans overall, including youth, as we'll say in a moment. Today, we're probably going to talk mostly about serious mental illness. That's a term of art that has to do with those people who are truly disabled, often by a psychotic illness. That occurs in about, overall, perhaps 1 in 20, so it's not quite as common. But it's an important piece of the story that we need to talk about because these are the people who are most severely impaired. As Pam mentioned, and as already mentioned by you, Senator Harkin, it's really critical for the committee to understand that unlike talking about cancer and diabetes and heart disease, when we talk about mental illness, we're talking about illnesses that begin early in life. These are, in fact, the chronic disorders of young people. And it requires a different mindset when you think about how do you detect, how do you intervene, how do you make sure that you can make a difference. That's one of the reasons why these disorders have the highest disability rating or the highest morbidity overall. It's because they start early and they tend to be chronic. As Pam mentioned, we know these are treatable disorders, but there's a significant delay in getting treatment, and even in those young people who have these most severe illnesses, like schizophrenia, on average, the delay between the onset of symptoms and when they get diagnosed and treated is somewhere between 1 and 2 years, which seems extraordinary because you're talking about symptoms that are so disabling and so obvious. And it's especially unfortunate because the lesson we have learned from cancer and heart disease, diabetes and AIDS is that the secret to having the best outcomes is early detection and early intervention. That's what biomedical research has taught us over the last 4 decades. You have to get there early in the process if you want people to have the best outcome. And we don't do that here. And I think one of the things we need to talk about, again, going back to your comment, Senator Alexander, about who needs help and who's going to be responsible for providing help, is why the delay and how do we do better in making sure that people get involved more earlier in the process. Just a comment about violence and mental illness, because it will come up, I think. It's on a lot of people's minds. As you've heard already, most violence has nothing to do with mental illness, and most mental illness, or most people with mental illness, are not violent. In fact, we generally worry more about people with mental illness, especially severe mental illness, being the victims, not the perpetrators of violence. And the science certainly supports that. There are 2 conditions where we do need to think about this because violence and mental illness will intersect. And one of those is these psychotic illnesses like...
Committee holds a hearing on the state of America's mental health care services. Health officials from the Obama administration examined current challenges, focusing on the relationship between mental health and gun violence. It's 2.5 hours.
The Senate Committee on Health, Education, Labor, and Pensions will please come to order. My first order of business this morning is to extend a warm welcome to our committee's new members. In alphabetical order, Senator Tammy Baldwin, Senator Chris Murphy, Senator Tim Scott, and Senator Elizabeth Warren. This is a remarkably talented group of freshman senators, and we're glad to have them on board. I know that some are also over at the hearing on the Senator Kerry's hearing to be Secretary of State starting at the same time. I also want to salute our new ranking member, Senator Alexander. He has long been a valuable member of this committee. I've appreciated my relationship with former ranking member, Senator Enzi, and look forward to the same kind of close collaboration and partnership with my good friend, Senator Lamar Alexander. Today, our committee will examine a range of issues surrounding mental health care in this country. The tragic shooting in Newtown, Connecticut last month brought the issue of mental health care to the forefront of public dialogue. Many people across the nation, including the President, have said that we need to take a long, hard look at access to mental health services across the country. I'm pleased to have this opportunity today to start that dialogue with my colleagues and our panel of expert witnesses. I'm told this is the first hearing that this committee of jurisdiction, has had on this issue since 2007, so it's long overdue. Certainly one of the most insidious stereotypes about people with mental illness is that they are inherently violent. I regret that some of the discussion in the wake of the Newtown tragedy has sadly reinforced this stereotype. As my fellow committee members know, and our witnesses and experts know, people with mental illness are much more likely to be the victims of violent crimes than they are to be perpetrators of acts of violence. Mental health conditions are sometimes called the nation's silent epidemic. Mental illness affects 1 in 4 Americans every year. But despite its prevalence, there is still a stigma attached with mental illness, and that stigma results in too many people suffering in silence without access to the care that could significantly improve their lives. Stigma also can stop workers from requesting and getting accommodations and that can help them be more productive at work. I've known so many instances of people who were afraid to do anything because they might lose their job. or they wouldn't get promoted because of that stigma that's attached. Unlike many other chronic diseases, mental health problems often begin at a young age. Experts tell us that half of all mental illnesses manifest by age 14. However, less than half of children with an identified mental health illness receive treatment. And the average lag time from the first onset of symptoms to receiving treatment is almost a decade. Unfortunately, the picture for adults seeking treatment is not much better. This lack of treatment has huge consequences. Some 30,000 Americans die by suicide each year. And it's a shocking fact that people with serious mental illnesses die significantly earlier than Americans overall, often from treatable causes like diabetes and smoking-related chronic conditions. These consequences also spill into other areas. As any teacher or school counselor will tell you, a child who is struggling with depression, anxiety, or any other mental health condition is also likely to struggle academically. It's also an issue for our justice system, since our prisons too often become the dumping ground for people who should be receiving mental health and substance abuse counseling instead. I have had a number of sheriffs in my own state, as well as other states, tell me that their jails are now the de facto mental institutions in their states. The shame in this is that with access to the right treatments and supports, most people with mental illness can recover and lead productive and healthy lives. But we need to make the critical investments that will enable this to happen. So wearing my other hat as the chairman of the Labor, Health, Human Services, Education Appropriations Subcommittee, I plan to take a close look at funding opportunities in this area through the appropriations process. We've made important steps forward in recent years. My friends, the late Senator Paul Wellstone, and again along with my friend Senator Pete Domenici,
22% of Tennesseans reported having a mental illness last year. That's more than a million people. This is according to our State Department of Mental Health and Substance of Mental Health. About 5% had a severe mental illness. That's nearly 250,000 Tennesseans. So that's a lot of people. About 41,000 Tennesseans had a major depressive episode. The funding that helps meet the needs for that comes in some part from the federal government. About 22% of what Tennessee spends, I'm told, is federal dollars. The rest is state dollars. In the community services, state appropriations are about 70% of the mental health fund. So while the federal government has a role here, it's a support role and a supplementary role, and it's a role that ought to make things easier instead of harder. In preparing for this, it seems to me that putting a face on the individuals who need help, one group would be a 9-year-old boy who's always been pleasant but suddenly started defying his teachers and his grades slipped, and he didn't want to go to Boy Scouts, he didn't want to play with friends, and so they reached out to a pediatrician who was able to get some professional assistance. He was diagnosed with a mood disorder, and he began to improve, was sleeping better, and so it was a success story for that 9-year-old boy. Another case might be an adolescent, a 17-year-old who had no behavioral issues growing up. He started noticing lights in the bathroom, sounds of water irritated him. He had trouble sleeping. He began to hear voices telling him to throw rocks at anyone who told him to come down from the roof. And he was finally diagnosed with schizophrenia, but only after he had multiple episodes. Those two boys represent two of the largest groups that need help, and I'll be interested in finding out from our witnesses how well we're doing in helping them get the help. Finally, I'll be especially interested in asking the federal agencies as well as the state and local witnesses who are here, what can we do at the federal level to make things easier to, number one, identify who needs help, and number two, identify who can provide the help? Are there administrative things we can do? Are there funding things we can do? Are we putting up any roadblocks that make it harder for you to provide services? If we are, this is the place to identify them and see if we can correct them. So, Mr. Chairman, I look forward to this. I thank you for holding the hearing.
Thank you very much, Senator Alexander. Now we'll turn to our witnesses. We have two panels. On our first panel, we'll start with Pamela S. Hyde, Administrator of the Substance Abuse and Mental Health Services Administration, obviously known as SAMHSA to all of us. Ms. Hyde was nominated by President Obama, confirmed by the U.S. Senate in November 2009 as the Administrator of SAMHSA. She is an attorney, comes to SAMHSA with more than 30 years' experience in management and consulting for public health care and human service agencies. She has served as a state mental health director, state human services director, city housing and human services director, as well as CEO of a private nonprofit managed behavioral health firm. Ms. Hyde is a member of or has served as a consultant to many national organizations, including the John D. and Catherine T. MacArthur Foundation, the American College of Mental Health Administration, the President's New Freedom Commission on Mental Health, and the United States Department of Justice. Our second witness on this panel, of course, is no stranger again to this committee, or at least to my Appropriations Subcommittee anyway, and Dr. Thomas Insel, who is the Director of the National Institute of Mental Health, NIMH, at the National Institutes of Health. He has been director since the fall of 2002. Prior to that, Dr. Insel was professor of psychiatry at Emory University, and there he was the founding director of the Center for Behavioral Neuroscience, one of the largest science and technology centers funded by the National Science Foundation. He has published over 250 scientific articles and 4 books, including The Neurobiology of Parental Care in 2003. He is a member of the Institute of Medicine, a fellow of the American College of Neuropsychopharmacology, there I said it, and is a recipient of several awards, including the Outstanding Service Award from the U.S. Public Health Service. So we thank you both for your backgrounds, for what you have done in this whole area of mental health, both in research and practicality, and your statements will be made a part of the record in their entirety. I'd ask, we'll start with Ms. Hyde, I'd ask if you could sum it up in 5, 7, 8 minutes, something like that, and then we'll get to some questions. So again, welcome, and Ms. Hyde, please proceed.
Thank you, Chairman Harkin and Ranking Member Alexander, for holding this hearing today. It's an important day. You will hear today about the prevalence and burden of mental illness and about the critical needs in our country for understanding, treatment, and support services for those who experience mental health conditions. SAMHSA's mission is to reduce the impact of both substance abuse and mental illness on America's communities, and there's significant overlap between those two sets of conditions. They currently exist largely outside the mainstream of American healthcare, with different histories, structures, funding, incentives, practitioners, and even in some cases, different governing laws. It's time that changed. SAMHSA envisions a nation that understands and acts on the knowledge that behavioral health is really essential to health, that mental and emotional health and freedom from substance abuse and addiction are necessary for an individual, a family, or community to be healthy. As the Senator said, almost half of all Americans will experience symptoms of mental or substance use disorders in their lifetime, and yet of the over 45 million adults with any mental illness in a given year, only 38.5% of them receive the treatment they need. And of the almost 22 million adults with substance use disorders, only about 11% receive the treatment they need. For children and adolescents, it's only about 1 in 5 that receive the treatment they need for diagnosable mental disorders. Cost, access, and recognition of the problems are the primary reasons this treatment is not received. However, it doesn't have to be this way. For most of these conditions, prevention works, treatment is effective, and people do, in fact, recover. And as Senator Harkin said, the Institute of Medicine reported in 2009 that half of adult mental illness begins before the age of 14 and 3/4 before the age of 24. We can and must intervene early to address these issues for our young people and for our nation. Behavioral health is a public health issue, not a social issue, and it can be tackled and addressed in an effective public health approach driven by data, focused on prevention and supportive policies and services that treat and restore to health. I'd like to talk about the Affordable Care Act for just a minute because it's going to provide one of the largest expansions of mental health and substance abuse coverage in a generation by helping over 65 million Americans have access to additional behavioral health benefits that they do not have now. The ACA has already provided screening for depression, suicide risk, and alcohol misuse in many service programs and in its quality measures, and it has already provided additional coverage opportunities for youth. It will ensure that insurance plans offered in the new marketplaces cover mental and substance use disorders at parity with other benefits and as one of the 10 essential health benefit categories. As part of the President's plan to protect our children and our communities, he outlined some specific actions and initiatives to help ensure adequate coverage of mental health and addiction services. The administration issued a letter to state health officials making it clear that Medicaid expansion plans must comply with the parity requirements of the Mental Health Parity and Addictions Equity Act of 2008, or what we call MAPIA. In addition, the administration will issue final regulations governing how existing health plans that offer mental health and addiction services must cover them at parity under MAPIA. The President's initiatives to ensure students and young adults receive treatment for mental health issues include SAMHSA-led proposals such as a new program called Project Aware, which would bring together state officials, schools, communities, families, and youth to promote safety, prevent violence, and identify mental and behavioral health conditions early and refer young people to treatment. Project Aware would also provide mental health first aid training. A proposed new grant program, Healthy Transitions, would provide a pilot to model innovative state and community-based initiatives and strategies supporting young people ages 16 to 25. Along with HRSA, the President's workforce proposal would provide training for more than 5,000 additional mental health professionals to serve students and young adults. And finally, with the Department of Education, HHS will soon launch what we're calling a national dialogue on mental health to help change the conversation and galvanize action about our children's mental health. We've come a long way in the prevention, treatment, and recovery supports for mental and addictive disorders.
Fought for years to try to enact a Mental Health Parity Act to end the absurd practice of treating mental and physical illnesses as two different things under health insurance. We finally passed that in 2008. However, I am sad to say it has been 4 years now, that we do not have any final rules on implementing this law. That's a shame. I am told the President said that they will be announcing a final rule soon. I don't know what soon means, but I hope it means what we generally take it to mean, which means soon. Another critical step will take place next year when, thanks to the Affordable Care Act, some 30 million Americans will become eligible for Medicaid or private insurance through the health care exchanges. Coverage of mental health and substance abuse disorder services is one of the 10 essential benefits required in qualified health plans. The insurance expansion here offers both challenges and opportunities. Experts predict that the newly insured population will have a greater need for mental health coverage than the general population. As we think about how to meet this need, there's an opportunity to realign our healthcare system to better integrate primary care and mental health services. And in reading over the testimony last evening of our witnesses, many of our witnesses spoke about that, this integration of primary care and mental health services. This committee, I think on both sides, have been very supportive of the expansion of community health centers throughout the United States. They've been a great addition. They're wonderful primary care providers. But how do we integrate mental health care services in with those community health centers and make sure it's part of primary care? 50 years ago, President Kennedy signed the Community Mental Health Act of 1963, which led to a major shift in mental health care in this country. People who were warehoused in institutions moved back into their communities. But the results were mixed. Many people were not able to access the community-based services and treatments they need. So as we face major new changes in the healthcare landscape, I hope we'll learn from these lessons. And again, as I said, see how we might more fully utilize the community health center system in America to integrate primary care and mental health services. So today we'll hear from a panel of expert witnesses who will talk about mental health care from a variety of perspectives, all with the goal, I hope, of addressing this critical but often neglected public health issue. I want to reemphasize that, my own words, public health issue. So I thank you all for being here. Look forward to your testimony, and I'll yield to our ranking member, Senator Alexander.
Thanks, Mr. Chairman. Thanks for your courtesy. I look forward to working with you. We've worked well together in the past, and this is a very important committee with a large jurisdiction, and I'm delighted to have a chance to be the ranking member. I want to say to Senator Enzi how much I appreciate his leadership, and we expect it to continue as time goes along. I also want to thank the chairman for having this hearing and the way he's having the hearing. I mean, we're entering this discussion, so far as I'm concerned, and that's my sense of the chairman's attitude, with no agenda other than to learn what needs to be done. As the chairman said, we haven't had a mental health hearing for a while, and so I'm here to do a lot of listening. I was saying to some of the witnesses before the hearing that when I was United States Education Secretary, I often was sitting in their shoes, and I remember going back and telling the people in the department that I thought I was going to a hearing, but in fact it was a talking, because the senators did all the talking and the witnesses did most of the listening. So I hope this will be more of a hearing instead of a talking, and I'll try to do my best to make it that way. Seems to me that the question before us is who needs help and who's there to provide the help. We can hone in on that question and see what the federal government can do to improve our ability to determine who needs help and our ability to identify the person or agency whose job it is to provide the help. Then we will have provided some service. Helps to put a face on who needs help. As a former governor, I always look at things from my own background and perspective, as I know most of us do, about